Okay. Right, then. Right, guys, we'll get started. Thank you so much for joining us here today. A warm welcome to everyone, just to here to help us celebrate World Kidney Day. A special thanks to Judy as well for taking time out to come and support. And I'd also like to say a special thank you to the committee that's helped today happen. Hamda Al-Habdeen, Emma Reid, Joy Kiat Floro, Sajamal Chanda and Catherine Burley for all the hard work in making today happen over the last 5 months. So just to say a bit about World Kidney Day, it's a yearly global campaign aimed at raising awareness of the importance of our kidneys, about preventative behaviours, awareness about risk factors and awareness about how to live with a kidney disease, because overall we want kidney health for all. Being diagnosed with a kidney disease can be a huge challenge. Its diagnosis, management, particularly in the advanced stages of kidney disease, impacts severely upon their lives by reducing their ability to participate in everyday activities like schooling and socialising, whilst causing numerous problematic side effects like fatigue, pain and depression. So here at Sidra Medicine, we see approximately 103 children in our chronic kidney disease clinic. Almost 60 of these are in CKD stage 3 and above, which means that soon in their lives, they will need to start some type of renal replacement therapy by means of dialysis and a transplant. We have 8 children that attend for our hemodialysis unit 3 times a week, and this can be up to 4 hours at a time. And we've also got 12 patients in the community that receive peritoneal dialysis overnight for 10 hours. So as you can see, this is a massive part of their life. Transplantation is considered to be the best option of renal replacement therapy for the child's quality of life. Currently at Sidra Medicine, we see 19 post-transplant patients. 7 of these have been transplanted at Sidra since the hospital opened in 2018, and making history in celebrating the first paediatric kidney transplant from a deceased donor in Qatar. We have a range of nephrology professionals here at Sidra Medicine, some of who are speaking today, and we're working together as a team to aim to prolong and preserve their kidney function for as long as possible in order to try and normalise their life and give them the best quality of life in order that they can live well with kidney disease. So just to start the day, part of the Scientific Planning Committee, we do not have any relevant financial relationship with commercial interest to disclose. Please, just a note to everyone, just to keep your phones on silent. Our learning objectives today is to educate, promote awareness about kidney disease, as well as CKD screening, management and treatment, to increase education and awareness about effective symptom management and patient empowerment, and to increase the awareness of the importance of preventative measures throughout populations and professionals. So just a fun little fact just to start the day, we're just going to be testing your knowledge. So please, can you try and scan the QR code or go to menti.com. So do we click on it? Oh, sorry. Is everyone managing? Okay, sorry. Yeah? Okay, guys, so, okay, what's the code for? So what are the primary functions of the kidneys? Need to give 3, just one word answers will be fine. Okay, so, oh, sorry. Okay, guys, so your answers are coming up now. Some great answers. I'm impressed. Yeah. Okay, fantastic. Some great answers here, as everyone says. Filters, excretion, fantastic. Removal of waste, yep, activate vitamin D, brilliant. Okay, so how long is a healthy kidney? So the answer, we've got 4.5 inches long, 7 to 8, 12 to 13 inches. What are we thinking? Brilliant. Yep. We all just copying off each other now. Okay, so yep, so answer is the first one, 4 to 5 inches long. So generally the size of a fist, that's the size of a kidney. So quite small but very powerful organs. So which of the following statements are false? Your kidneys make urine, your kidneys remove waste and extra fluid, your kidneys help your bones, your kidneys filter cholesterol, and your kidneys control your chemicals balance. So which one is false? So we're looking for the false one, guys, yeah? The one that's not true. Yeah, good, okay, perfect. So, you can see the answer? No. Okay, so the true answer is your kidneys do not filter cholesterol. All the rest of them, they do, and they're very important factors. Okay, so well done to 53%, who got it right. So again, which of the following statements is false? So you can live a healthy life with one kidney. If it took all your nephrons in 2 kidneys and lined them up, you would reach almost 10 miles. And the entire blood in the kidney gets filtered around 2 times a day. So which one is not correct? Okay. Perfect. So, yep, great. So most of you got that right. The entire blood in the body gets filtered around 2 times a day is actually incorrect. The true answer is it actually is filtered 400 times in a day. So give one of the 8, like no cheating now actually, give one of the 8 golden rules for preventing chronic kidney disease. Perfect. So I can see you can all read well. Do not smoke, keep fit and active, drink water, exercise. Yep, do not take drinks or drugs. Perfect. Okay, brilliant, guys. Yep, as you can see there, 8 healthy tips for the kidney. And 8 golden rules for preventing chronic kidney disease. Yep, so as we said, keep active and fit. Is this another question, actually? Yeah, sorry, yeah. Yeah. And what is the most common risk factor for chronic kidney disease? diabetics, yeah. Hypertension, diabetes, great. Blood pressure, diet. Yeah, perfect. Does it go on to the answers? Yeah. So some great answers there again. And do we go on to the, yeah. So the most common risk factor is diabetes, and that obviously is still applicable in children and adults. We do see a lot of children who have diabetes that are beginning with some kidney disease. So individuals affected by obesity have, so just some choice of answers here, 83% increased risk of developing kidney disease. They are completely unrelated, 8% increased risk of kidney disease, or 50%. Which do you think is the answer? Okay. Okay, so the answer is that 83% have an increased risk of developing kidney disease. So as you can see, obesity is a massive factor in chronic kidney disease, and hence also why we need to be looking at our golden tips as well. Okay. Oops, sorry, has that gone on to... Yeah, well, that just gone to Dr. Imams. Okay, so thank you for that. So just an enjoyable little quiz there. So now I'd like to move on to our first speaker, who is Dr. Imam. So Dr. Imam completed his residence training chief residency in 1998 in New York, and then completed his fellowship training in paediatric nephrology in 2001. He joined the faculty at the Children's Hospital of Michigan Wayne State University in 2001, and he became the director of renal transplant program from 2003 to 2006 at Michigan Wayne State University. He joined the faculty of Akron Children's Hospital in Ohio as associate professor and chief nephrology from 2006 to 2009. He then became the head section of nephrology at King Fahd Medical City in Saudi Arabia from 2009 to 2012, and then came to Qatar as the head of paediatric nephrology at Hamad Medical Corporation in 2012. So in 2017, Dr. Imam came to be our division chief of nephrology at Sidra Medicine. He's clinical professor of clinical nephrology at the College of Medicine, Qatar University, and associate professor of clinical pediatrics at Weill Cornell. He is both a board certified by the American Board of Pediatrics in General Pediatrics and sub-board of pediatric nephrology. He's also a member of many international organisations and many publications in the field of nephrology and transplantation. So welcome to Dr. Imam, and thank you for coming.
Thank you very much, Charlotte, for this kind introduction. It gives me great pleasure to be here with you today. It's really impressive team that we have here. Just to give you a history of how the World Kidney Day started in 2006, International Society of Nephrology started this action with other societies involved. Their main point of establishing such special day, I always think that every day should be a kidney day. But they dedicated this day all over the world to raise the awareness of the people in general and medical professionals specifically on the importance of the care for the kidney and be the guardians for the kidneys from pediatric age group throughout adulthood life. And with that, they establish certain themes every year. This year is living well with kidney diseases, and this is important to get everybody talking the same language and dancing with the same rhythm. I have to thank the organizing committee that we have here, wonderful people. We establish every year at the end of the World Kidney Day, we tell them that, well, what is the next year plan and what are we going to do next year? Every year we get some challenges, and as you guys know that in 2020, we had the coronavirus that hit us hard all over the world, that impacted us negatively in the sense of establishing the activities that we usually do. The main point of it is gathering the children, gathering the families together to go out. We have the marathons and walkathons and group activities that were not able to do last year because of the corona restriction. This year, we're doing it much more controlled with celebration for our children down here, as well as in all patients with chronic kidney disease or adult at HMC. We're still participating with their activities over there. On Saturday, there is also a presentation they have with the teaching activity. One of the most important things about this day is raising the awareness with education. And part of the education is we're going to go in depth in certain knowledge that I'm going to take you through the kidney. And I like the questions that have been asked because that sets the ground for me to proceed with that. You have to remember that the nephrology team in general is not only certain people. It involves everybody, and starting from child life and going through social work, going through psychology, going through transplant coordinator, nurses, physicians, and administrators and dialysis nurses. I look in this room, technologists. I look in this room and I can see that it's a wonderful team to have. And I would like, on behalf of Sidra, on behalf of the Division of Nephrology, to thank you all for the great work that you all are doing for these children. With that, I will start my talk today. I have no relevant financial relationship to disclose. I'm just going to go through, in my learning objectives today, is to describe some spectrum of kidney disease in children, describe the management approach for children with chronic kidney disease. And for me to do that, I'm going to dive with you into the kidney in certain diseases. I'm not going to highlight all the diseases that the kidneys will have for children, but certain diseases that, to give you some sort of understanding, take you down to the kidney at a small level. And then we'll identify certain strategies for prevention of progression of kidney disease. The spectrum of renal disease in children ranges from antenatal diagnosis of abnormal kidneys in the fetus to a spectrum of diseases such as nephrotic syndrome that we all care for children with these problems in the outpatient and inpatient service, to glomerulonephritis, acute inflammatory process that happens to the kidney, to obesity and hypertension. Obesity and hypertension, I'm going to show you some data to tell you that it's becoming one of the major problems that we're facing in the youngsters and adolescents that we're caring for here. We know that in healthy normal children, growth is a complex problem that we face. The difference between an adult nephrologist or an adult nephrology service and a pediatric nephrology service is, for the adult, they don't have to worry about the size of the person in the sense of growth. You have to remember that in pediatrics, we are trying our best to maintain a normal growth for a child. We have growth curves that our dietitian, a major important person in the team, a person that takes care of from birth all through adolescent life, that the person is appropriately growing. And I learned a lesson while early on in my career. A pediatrician, or my program director, told me that if you are going to be, by any chance, a good nephrologist, you have to be a good pediatrician. And for you to be a good pediatrician, you have to pay attention to growth. So the growth of a child is an important aspect for the care of these children. You have to remember that for any child to grow, certain standards have to be built. Certain requirements have to be met, whether it's a caloric statement, that is enough calories, whether there is a normal acid balance in the body that's needed, and we're going to go into that in a minute, to all the growth needed, the growth factors that's needed to make the child grow. Now, we know that in children with chronic kidney disease, the growth is affected for many factors. Those children don't have the right appetite to eat. So the dietitian will work with them to figure out what is the appropriate type of food that they need, the caloric intakes. They need specific medications to control their acid production in their body, to buffer the acid load. Why? Because if we don't have a normal acid balance, all the enzymes that we're using in our body to grow or to have any function will be defective. If you remember that any enzyme to work, it needs a specific pH, specific acidity that's needed for the enzyme to work. Now imagine that enzyme is not working. That means all the growth that is going to be expected is not going to be there. So it's not only calories, it is also the milieu of the environment that the child is in. Come into that, the psychosocial effect of the availability of the food, the acceptance of certain types of cultural changes in certain communities have an impact on the type of food that we depend upon for these children. We know that in healthy normal children, growth is a complex problem. However, we know that it influenced by a lot of factors. We have genetic factors that are affecting each population, each ethnicity, each group. And we know that there is environmental factors. What exactly the patient is on? Are they available environments? Where are they going to be? And depending, you practicing in Alaska in the United States is totally different than practicing in the desert of Africa, different in the Middle East. So different environments are available there. But one of the most important common factor is also the psychological and psychosocial involvement factors. That's why in each unit, in each nephrology care, the presence of the social service, social worker is of great importance in these programs. I'm going to touch and I'm going to share with you just a question that came out about the correlation between obesity and the chronic kidney disease. And it's becoming like an epidemic. That epidemic is not restricted to a certain area, all over the world. From the United States to Japan to everywhere, the people were facing this problem as part of the changes we've been having in our lifestyle modification, lifestyle that changed if you look at 30 years, 50 years ago to what we're doing right now with the type of food our own children eat. This is something that we all face it as part of our lives. Now, I'm going to, in the next few minutes or so, I'm going to share with you certain information. I want you to pay attention to it. This is part of the knowledge that we want to make sure that everybody understand as basic understanding. You know, the principle of this, or the main idea of it, is to just have a global outlook of what those children might have. We see them from outside, could be normal or cheerful, but from inside, an ultrasound of this child antenatally before get born, showing to us that this dark area here, and this is the kidneys. This is what we refer to as hydronephrosis. Hydro means water, nephrosis means the kidney. So it's like a water in the kidney. This hydronephrosis indicates to us that there is some sort of an obstruction as the kidney goes down, or there is a reflux from down up. We don't usually know the exact cause of it until we scan further. If you scan further down the kidney, you see this is the ureters. And every time you have a big ureters, you start to think about if the kidney is, and it's like I call it a detective work, that you look at, if the kidney is obstructing, now I see the ureters. What would be the obstruction? The obstruction could be distal part of the ureter, or it could be a reflux going all the way, dilating the whole system. If it is that, we do what we call it avoidance hysterourethrogram. We put a catheter on these newborn babies, and those in NICU will attest to what we're saying. We put a catheter in the kidney, and we put a contrast in the bladder, and you could see the reflux, the level of the reflux going all the way up. We ask the child to urinate. Why? Because in boys, we gotta detect this problem here. You could tell that this is a posterior urethra. There is a change in the caliber of the urethra here and here. And this indicates an obstruction here, what we call it posterior urethral valves. If you look at a kidney afterward, this is a postmortem pictures, you could see how dilated actually the way it looks. The pelvis of the kidney is dilated. This is how the bladder look. And I can tell you, we do have children with such bladder. We call them hostile bladder. Look at this muscle of the bladder. Why the muscle developed? Because the obstruction is down here. The bladder during development is trying its best to excrete, get rid of the urine. So it develops muscles as the child is growing. Then the child get born, get this kind of bladder. Now, you can tell that our partners here are the urologists. We cannot work as a group of nephrology with all the team we have without a competent, great urology service. That's why the presence of urology and nephrology coexists in any great center. And we are very blessed to have a great team of urologists down here, world-renowned people that they know what they're doing to do all this. Now imagine you gotta use this bladder and the kidney failed completely. And now the patient on dialysis, and you need to do a kidney transplant for such patient. And we do have these situations all the time when we face it. This bladder has to work to prevent the new kidney from being damaged. So all that, when you put it together, you gotta understand why it happened and how it happened. But as the child is growing, I'm not going to make it complex for everybody to remember all this. Just think about it that we do have what do you call it, the glomerulus, where we have the blood coming in and all the situation. We have a tubules, we call it the proximal tubule. This is the glomerulus here. This is where the filtration takes place. When the filtration takes place, it goes into a funnel. And that, it goes into what we call the proximal convoluted tubules, and it goes through the nephrons. And if you imagine the kidney in its best shape, normal shape, its job is to filter and claim back what we need and let go for the waste product. This is what we call it the loop of Henle. In the loop of Henle here, we have certain medication we use, like furosemide, Lasix, that works on certain reabsorption of sodium, and I'm going to show it to you in the next slide. And then it goes into the distal part of the nephron, we call it the distal convolution tubule, and then the collecting ducts. And it will go out after we filter everything. We claim back the urine, the fluids we want, the water we want, through this, what you call it, a counter-current mechanism, reabsorption of water. Let the waste product goes out. Sodium is an important element that we have to care for. Why? Because sodium is needed for every growth of any child. If I have a child who's a salt waster or a salt waster urinating so much of urine because of a defect in the reabsorptive mechanism, those patients will not going to grow unless we supplement them, because you need sodium for all energy. All the cells need sodium to function for all the enzymes to work. We have a decrease in the reabsorptive mechanisms due to impaired certain enzymatic activities. Acidosis, as I mentioned to you, is an important one. You have to remember that in certain parts of the nephron, there is what we call it the proximal handling or proximal acidosis due to the kidney, renal tubular acidosis, or distal tubular acidosis, that's where the handling of potassium and hydrogen ion takes place. If you have any defect, your end result is what we call it renal tubular acidosis, and different types. But the one that we see it with the obstructive that I described to you earlier with those baby with posterior valve is what we call it type 4, that we have an issue of excretion of hydrogen ion due to aldosterone being impaired in the response. This is an important diagram. I call it filtration takes place here. Just bear with me. Imagine yourself a waste that's coming out all through the proximal tubule. Now the kidney is like, okay, I need to balance the acid. I need to reabsorb the bicarb through a certain enzyme. So if I have a defect in this enzyme, I will have a problem of reabsorbing bicarb. The end result is a lot of bicarb will go all the way through, and you develop acidosis, what we call it proximal tubular acidosis. Now you come down, you are still diving there. Sodium comes back here, reabsorbed back into the blood. 65 to 70% got reabsorbed. Water, as you go, also gets reabsorbed in this part of the nephron. Here, another mechanism, sodium, also gets reabsorbed. That's where the loop diuretic, the furosemide, works. And if I block it here, a lot of sodium will come out, around 25% comes out. Now in the distal convoluted tubule, around 5%. Here where the thiazide works. That's why the diuretics that works here on 25%, such as furosemide, are stronger than the thiazide because it only handles 5% over here. And then it goes all the way until what we call it the ENaC, or epithelial sodium channels. Here is 1 to 2%, and this is certain medications here block it. This is where spironolactone work, and this is where amiloride work. So understanding that if I use this medication here, spironolactone, it will be weaker compared to this one. This is 5%, this is 1 to 2%. It will be weaker than if we use the loop diuretic here. The end result is urine getting secreted out. Here, the major absorption of water back into the system takes place here through the antidiuretic hormone. This is the last checkpoint of the urine going out, or the filtrate going out. The kidney claims back the water back, because we do not want to be wasting there. Those who have a problem with this hormone develop what we call it diabetes insipidus. They pee a lot. They are not able to concentrate the urine. That could be congenital, could be genetic induced. Normally, just for us to know, what we call the normal anion gap. We look at the serum sodium, we look at the serum chloride, and we look at the bicarb in it. This is what we call the normal anion gap. We have a certain number that if you are up to 8, then you have a normal anion gap. That means what? The problem in the kidney or the gut. That's where the control. Now, if it is not normal anion gap, that means there is a lot of production of acid, such as DKA, patient diabetic. Their problem is not the kidney. Their problem is the ketone that's being produced that will give you a high anion gap metabolic acidosis. So we talked about the types of the proximal, the distal, the hyperkalemic, the type 4 that I mentioned to you with obstructive uropathy. I showed you that in the proximal one, there is a common disease, we call it Fanconi. And we do have patients with all these problems I just told you about. In Fanconi, children present with a lot of calcium secretion, a lot of glucose in the urine, although they're not diabetic, because glucose gets handled in the proximal part of the nephron. Hyperuricosuric, uric acid, proteinuria, and this proteinuria is mainly what we call it low molecular weight proteinuria, that there is a problem of the reabsorption of small molecular weight protein, not albumin. I'm going to go into that in a minute. Now, why? Well, we have a problem of endocytosis in Fanconi. Those patients have severe hypophosphatemia, failure to grow, and they have problems with endocytosis. What's endocytosis? Well, endocytosis is a reabsorption in the proximal tubule. And now imagine you are in the proximal tubule here. This is a proximal tubule. In the outside of it, there is a more like a device that attaches the protein to go in all the way. And as soon as you drop the protein, the black one here, it gets recycled to go out again to bring. So almost like a chaperone, or almost like a constant Uber. Take a passenger from here to the destination and goes back again looking for another passenger to come. And if you have a defect in any of this problem, whatever here, it's not going to be reabsorbed. This is what we call it the endosome, and this we call it the lysosome. Any problem of handling the protein here will give you certain diseases that we know. Now, we know that this dissociation, how does that happen? How does the protein goes from the outside to go in? It's all dependent on hydrogen, ion, and the chloride channel. Just for you to imagine it, if this is the endosome, a hydrogen ion, the hydrogen ion comes in, hydrogen ion goes out, chloride comes in. So imagine any problem of this defect in the chloride channel or a problem here will give you specific disease. Any situation that give you this will be defective problems, and it could be a disease. So if you understand the principle there in that situation, you'll be able to manage it accordingly, and apply the right therapy for it. I'm going to switch gear here, and I'm going to tell you about nephrotic syndrome, a very common problem we face all as teams in this hospital. There are different types of nephrotic syndrome. There is something we call it congenital nephrotic syndrome, and by the way, we do have actually patients exist in our service at the current time with all these problems that I'm talking about. Congenital, the baby was born with a problem. Within 3 months of age, if you diagnose the problem, then the patient is congenital nephrotic syndrome. Infantile, up to 1 year of age, from 3 months of age up to 1 year of age. And then minimal change disease, which is a disease that is very common that we give the steroids for. We sometimes face with those who are steroid resistant, we call them focal segmental glomerulosclerosis, mesangial proliferative, membranous, and other diseases. But why it happened? Well, different theories play a role here, whether the size of the protein or what is the charges. If I tell you that this is the glomerulus that I mentioned to you earlier, now if I cut it a little bit in a smaller piece and I try to think about it. Now, this is a capillary space that I'm talking about from inside. This is the lining cells of the small vessels, we call them endothelial. This is the basement membrane that protects things from going out easily, and this is the urinary space. And in this guards, all of us has this, what we call it, podocytes. Their job is to guard the kidneys from letting go of proteins. Now, there is what we call the negatively charged basement membrane, and this is a protein that's albumin is negatively charged. It will repel each other. So if you have a defect in your basement membrane to be a positive, you will have a problem with a protein coming out. Now, if we go small electron microscopy, small, or high magnification to a smaller unit, this is exactly how it looks in real life. This is the podocytes, this is the basement membrane, and this is the endothelial cells. The complexity of these podocytes creates a lot of pressure on understanding the disease itself. Any mutation that happens in any of these proteins that are responsible of the cytoskeleton of the kidney, it will result in a defect. This is this pink one, we call it the nephrin, and the nephrin is the one that get defected in patients with congenital nephrotic syndrome. When we lose the ability, remember the guards are sleeping right now. You can tell them they're flat. We call them flat or effaced basement membrane, the podocytes. Now, the difference between glomerulonephritis and nephrotic syndrome is an inflammatory process. I explained to you right now, nephrotic syndrome is a defect in a certain ability of the kidney to keep the protein in. But in glomerulonephritis, the name indicates an inflammatory process, not an infection. An infection, we call it pyelonephritis, that you have an infection, a bacterial infection, or that causing this problem. A glomerulonephritis is a common problem that we face, and it have different presentations. We call them the low complements, and the complements is the immune system monitoring of the activity of the kidney. There is a department in that immune system focused on the kidney itself and the integrity of it. Certain diseases, common, give you low complements such as post-infectious. A child comes to you with a strep throat 4 weeks ago and then develop a glomerulonephritis, evident by blood in the urine and elevated blood pressure. Other diseases will give you normal complements, and that normal complements will put you into what exactly involved in this disease. Different diseases will give you this problem. We have to remember that there is something called rapidly progressive glomerulonephritis. And those in our dialysis unit, they don't like it. because it indicates that we need to do dialysis immediately because the kidney is losing its function as we speak. In every minute, every hour, we lose a function. And this is specifically we call immune complex mediated, such as lupus patient or antiglobulin-based membrane Goodpatcher's disease, or post-immune, such as what we call it Wegener's granulomatosis. Certain diseases that give you this. The end result is acute kidney injury, and that are the patients that either we do hemodialysis for them or we do continuous renal replacement therapy. Of all the important things that comes with acute kidney injury is hypertension. And we have to remember, we have different definitions of hypertension. We call it hypertensive emergency. If I have acute severe blood pressure elevation producing severe life-threatening CNS or cardiovascular symptoms. It can be hypertensive encephalopathy seizures, or it can be what we call it posterior reversible encephalopathy syndrome. And I'm telling you, we do have patients with this problem right now as we speak in the hospital that we care for. This patient can develop congestive heart failure from the high blood pressure that they have, and papillary edema, or what we call it in CNS involvement. How do we treat it? Well, we have to give continuous IV infusion to allow controlled blood pressure reduction. These patients, we cannot go from severe hypertension to normal blood pressure. The brain, remember the brain is sitting in a limited space. Get used to this high pressure. You cannot just all of a sudden bring it down to normal. The perfusion to the brain become defective, so you have to be gentle, lowering of the blood pressure in the intensive care unit using certain drips. Sodium nitroprusside, labetalol, and nicardipine drips, titrated measurement. When do we call it hypertensive urgency? Well, the patient is having symptoms, headaches, but did not yet develop seizures. It might progress to hypertensive emergency, but not yet there if it's not controlled. Again, those patients, you need to drop it by 20%, not all at once. Within 1 hour, you can use oral medications for them. You gotta keep close look at them. Now, if we don't do anything for a regular hypertension child who's been running around, those children will have hearts that looks like old people in their 70s or so because of the long-standing hypertension. The long-standing hypertension, the heart is trying to compensate by developing muscles to override the pressure. The end result is big muscles compared to normal muscle size here. This is what we call it left ventricular hypertrophy. Why in the left side? Because it's what we call systemic hypertension. The pressure in the aorta, the resistance there, is the one that applied to the left ventricle. That's why these patients, when we see them, we request an echocardiogram. Now, a problem that, as I told you, is becoming of a major concern for us is obesity. And obesity results in reduced insulin sensitivity and a state of hyperinsulinemia. Again, this is a situation where a child who is a teenager have a disease of people in the 60s and 70s of age. You will have impaired glucose tolerance because you have an effect of the insulin. You will have, which is to a degree that results in almost on type 2 diabetes. You will have a problem of a lot of oxidative stress release because this is more or less like an inflammatory situation. A child who's obese is not a healthy child. You have to remember. Now, nitric oxide will be affected. All pro-inflammatory cytokines are definitely affected. Angiotensin 2 is increased. With the effect of it is further hypertension. So obesity and hypertension are linked. So you develop hypertension, increase intraglomerular pressure, and when you develop increased intraglomerular pressure, your kidneys right now are affected negatively. And all this result in an injury to the kidney. Now imagine the kidney with all its sensitive capillaries inside, having a lot of pressure, stress, high blood pressure. It will cause what we call it a tear and shear effect on these organs. You will have protein excretion rate increase. That will affect, again, the activity of the kidney. And renal growth will be affected, mesangial cells, proliferation. Ideally, look at this, the tubular reabsorption. Remember I showed you the reabsorption? We have problems of the reabsorption, decreasing secretion of sodium. What we call it, almost a child is like retaining salt, becoming more hypertensive, cannot excrete sodium. Remember I told you, too much sodium is not good, too little sodium is not good. Too much sodium will give you hypertension, too little sodium, the child doesn't grow. So state of obesity is an abnormal state that is the child is living. In children with kidney disease, now imagine a child with kidney disease. Many disturbances in the normal physiology affecting their growth. Now, imagine a child that I said has already a problem and now he become obese. We got bigger problems. Like state of hyperinsulinemia directly or indirectly affect the physiology of the kidney. Progression of kidney disease become worse in patients who are chronic kidney disease. Now, dyslipidemia in overweight children or adolescents associated with kidney stones. Does anybody link that? Well, there are a lot of literature telling us that there is a relationship between that and renal stones in children. People went further to other diseases, HSP or Hanisch-Klein-Purpura, patients with IgA nephropathy, all the diseases I mentioned to you, glomerulonephritis. You wonder why? Because the patient become more or less in a pro-inflammatory state, susceptible to, this is what I call it, the environmental factors that I mentioned earlier. It does not directly affect, but it sets the body of the child for these diseases. And even children with type 1 diabetes have an effect on that. Now, we talked about the prevalence of hypertension increased progressively with increasing body mass index. We noticed that the higher you have, and we showed why, reabsorption of salt retention state. 30% in overweight children, BMI more than 95, do have hypertension, frank hypertension. Overweight and high blood pressure are components of insulin resistance syndrome, what we call it now, the metabolic syndrome. Risk factors for disease and type 2 diabetes also. Other abnormal factors or factors that such as abnormal lipid profile, truncal obesity, hyperinsulinemia, and we have all the data that it has significantly greater presence, greater in patients with high blood pressure than those with normal blood pressure. People even went further. Look at urinary tract infections and reflux. They say that those who are not obese, this here are overweight group, this is obese group. You could tell that their white cell count is even higher. Their CRP, the inflammatory markers, are even higher, and ESR. So all what that tells us that being obese is a pro-inflammatory state, especially in children. And people have identified that obesity is an independent risk factor for CKD, or chronic kidney disease, in children. So what can we do to prevent such thing from happening? Well, prevention is what we are always up to, because it's better to prevent than to face. How are we going to prevent? Well, for those who are healthy children, we need to pay attention to obesity and hypertension and the progression to type 2 diabetes. Education as much as possible to parents, to the community, to schools, addressing the importance of diabetes as an emerging epidemic in the community and the world. At the same time, the importance of paying attention to the type of food those kids eat. And I know this is very difficult. It's not easy and it's not simple to do that. It is easy to go for an easy fast food for those children, and the children love it, love it. And I started to think about there's the bigger scheme of, it's not only the children here, or it's all over the world, all over the world. So what is the common factor? We need to learn from these companies. How do they do that to make them this way? So we start think about the same strategies to make a child choose a salad or a fruit instead of cheeseburger or French fries. Psychosocial factors are very important, that we do play a significant role of the team approach towards these problems that we face in patients who are already having diseases. Now we need to slow the progression. Those who are born with defective kidneys could be genetic or could be non-genetic, but the most important is to protect it throughout their lives as we care for. And those who are having a genetic family history of genetic diseases, or an antenatal ultrasound telling us there is a problem, we need to detect it early and refer early to the unit that's care for those patients. We have diseases such as autosomal dominant polycystic kidney disease, focal segmental glomerulosclerosis. We know that those patients will have. It's our job to look at them and care for them early on before problems start to come. Now, if we detect it early, the expectation is that we intervene early. Now, for us to intervene, we need to have an integrated healthcare system from primary to tertiary. A patient routine check for urine, routine check for blood pressure, routine check for growth parameters, an early refer for a specialized unit taking care of all this problem. And it needs a team approach. It needs a team approach. I can tell you that it takes a village to raise a child, and it takes more than a village to take care of a patient with chronic kidney disease. This is my last slide, and this is talking about the layers, the care that we provide for all these patients has to be family-centered, patient-centered care that address symptoms and life impacts. Those children can have fatigue, can be tired. Their mobility might be restricted because of the growth and the bone. Remember, I told you that you need all this pH, you need all these needed elements. It's for the growth of the child. And the bones are important parameter for this patient. I can tell you, these patients sometimes undergo major surgical orthopedical procedures, and we do have those patients currently admitted under this service undergoing such procedures. We have to remember that some of them might develop pain. Management of pain in those patients is very critical. Stress and anxiety. Imagine a child at early age anxious about his whole existence, his own disease. And not only the child, the family, the parents. the integrity of the unit of the family. That's why the psychosocial is important. Depression. Now, with the COVID-19, and we felt the depression effect on all of us or our loved ones. Now, imagine a child who is chronically ill and have to face his illness as well as the fear of the unknown. So that effect is, in my opinion, magnified to higher levels. Some of these children have cognitive impairment, sleep problem. They don't sleep well. And cramps from the calcium, phosphorus disturbance. Some of them develop restless legs, gastrointestinal symptoms, diarrhea, constipation, all that. Now, we have to address their life impacts, their ability to work, if you're talking about an older people. But here I call it the family unit, ability to work, because a child who is having chronic disease or chronic kidney disease specifically, affecting the whole unit of the family. Ability of the parents, did they lose work, did they have job, they are available, what's the work? Because we do have a lot of visits. Sometimes they have to come to the dialysis unit 3-4 times a week for long hours. Who on earth we're going to employ somebody who's not going to be coming all the? So family, we have to respect their ability to work, ability to travel, to study. Impact on the family and friends, they cannot be available at all times, especially in a situation like this. What is the financial impact? That's why a financial help in those patients, understanding. In any part of the world, patients, this type of diseases are very expensive to treat, because dialysis in general, for example, or transplant, and specifically, can cost a lot. And that's why financial impact should be done. Dialysis-free time, dietary restrictions. Imagine a child that they love to do something. They like chocolate, and you tell them, sorry, you can't have chocolate. You gotta have to be able to give them an alternative to it. Lifestyle changes and social activities that are needed. A strengths-based approach, that communication and education of the child and the family build resilience, that you are not on this alone. You can do it, and we can do it with you. The word that you always tell the parents when a child referred for a chronic problem, I say, you are not in this alone. We're all here with all the team here. Their main job is to help this child. You as parents will help us from home, will help you from here. Our job is focus on the child and the family. It strengthens social connections, increase awareness and knowledge. So if a patient like this end up in the emergency room or end up in other places, people will understand. That's why education of the emergency room team and conducting all these activities of and making people understanding certain pathophysiology. And I'll tell you one thing that I learned throughout my life, that the kidney is an intimidating organ. A lot of people they got intimidated with the details about the sodium, the potassium that I just showed you. But if you just pay attention to how it works in simple terms, I like to make things very simple to people. That, listen, he's a salt waster. So he comes to you, he needs salt. Or he's a salt retention. If he comes to you hypertensive, don't give him salt. The one cut fits all doesn't work here. Every child have to analyze. If the patient is not making urine, is he dehydrated, needing more fluids? And I can tell you what parameters you can do. Or you need to restrict, because if you give him more fluids, he will flood his lungs and will end up in the ICU. That's what we call it, the understanding and awareness and knowledge of people working especially in the medical field. Access to support. They need to feel that they can reach us at all time. I can tell you, my WhatsApp is killing me at all times in the day about questions. And I can tell you, and access to our dialysis or transplant coordinators, they are becoming part of the family. They become part of the family. Any problem, they are the one who will be called first. That feeling of safety network for these families makes a huge difference for them to survive the stress that we have. Build confidence and control with self-management. Let them get the child to do things on his own, control certain things on there. Our job as clinicians, as all care providers, we to preserve the kidney function as much as possible. How? Well, I like to restrict the nephrotoxic medications that we give as much as possible. Patient-friendly lifestyle and diet. And here the dietitian role comes very, very clearly. The social help that the patient needs, the play therapy, get the child out of the zone. Don't think about yourself as sick. Think about yourself as a normal child. And we will have a nice presentation subsequently talking about this. Now, a patient needing dialysis, we don't just throw them in the cold water. We introduce dialysis for them, which is the best modality. We have different type of modality. We have the peritoneal dialysis and hemodialysis. Which one fits the child, fits the family? And that takes a lot of energy from all of the team to explain to the parents. A parents of a child going to be on dialysis is really, really, they're really scared. Why? Long time ago, dialysis was synonymous to death. So those who goes on dialysis, they end up dying. And that's where what we need to change on them. No, that was long time ago. Right now, we have modalities of therapy. We have the ultimate goal is to transplant this patient. This is the best. And the World Kidney Day is stressed on that as part of their main objectives, is to raise the awareness that dialysis is a bridge towards transplant. And that transplant is the best modality, especially for children, because that brings them back to the society as a functioning unit there. Patient-centered dialysis, patient-centered care, and prescriptions we need to minimize all the time. We sit down every month on dialysis, going on every medication. What can we cut down to make it easier? A medication that can be given during dialysis by IV will be better than getting at home by mouth, because we all know that if I tell you right now, take this medication daily, you forget when you're there. But in these patients, their body is very sensitive to these medications and so forth. And all efforts to preserve the kidney function as needed. Control of the blood pressure. Take your medications. Make sure that your lifestyle is appropriate, your diet is controlled. With this, I reached to my last things before raising the time is over, and I'll be more than happy to answer any questions that's needed. Thank you very much.
Okay, well, thank you very much, Dr. Imam. Thank you. Okay, guys, so Caroline. So our next speaker is Caroline, our dietitian. Caroline came to Sidra with 6 years of experience of working in the UK, providing support and advice to children with varying medical issues in both acute and outpatient settings, and finally specialising in children with chronic and acute kidney disease. Prior to this, quite interestingly, she worked as a chef for 15 years, using her clinical and industrial skills in helping families in her current role with the nephrology team here at Sidra. Thank you. Welcome, Caroline.
So thank you for the introduction, and before anyone asks, no, I'm not going to cook you any food. I think everybody should cook me some food. So I think, we've been involved in this World Kidney Day for a couple of years now, and we've had lots of different themes. And I think when I first thought about the theme for this year, which is before I start, I don't have any commercial interest to disclose. I found this quite interesting because, I think as clinicians, I'm involved very well in trying to educate the families on their dietary restrictions. The doctors are focused on lots of different things, but really it forced me to focus on what the families, like, what is it like for these children to live well with kidney disease? And it's actually something that I've probably not put a lot of thought into before. Okay, so the learning outcomes, understanding the nutritional restrictions that our patients with CKD face, dietetic input, what my days look like, the type of patients that I see, recognising the types of dietary restrictions that the families are on, and healthy eating in the early stages of CKD and throughout. Okay, so I thought this was quite a good slide to kind of show the difference in the levels of. Sorry, okay, so I thought this is quite a busy slide, but I thought it showed the good kind of levels of the different kind of aspects that we're treating. Primary CKD prevention, like Dr. Imam talked about, obesity, diabetes, controlling that. Secondary prevention, slowing the progression with hypertension. Is there any kind of small dietary restrictions we can place now? And then moving on to our work here at Sidra, the tertiary prevention, acidosis, bone mineral disease, fluid overload, cardiovascular disease, etc. But I'll go on to that in a bit more detail through the presentation. Okay, so I didn't ever want to be a renal dietitian. It's something that I was kind of forced upon, a part of my rotation, and when I worked in the Children's Hospital in Glasgow. Like Dr. Imam said, people get very scared about the kidneys, and like I still do. It can be very, very complicated. But what I love about it is that every single patient is very, very different. We know all the diseases that Dr. Imam talked about, which we have inpatients and outpatients. Really, we know what's meant to happen, but every single one of these patients is very different, okay? So one of the learning outcomes, as I go on, we'll talk about the high phosphate, high potassium in a bit more detail, but certainly there's lots of different aspects that we need to control, okay? The urea, what we find is that children with progressing kidney disease that have high ureas, they tend to not eat as well, okay? That may be a sign that their kidney function is progressing, or that they need to start dialysis, but really these children, they tend to just feel a bit sick, a bit nauseous. We rely sometimes quite heavily on enteral feeding to get these children to grow. We have, especially in our dialysis patients, sometimes lots of different restrictions that can be difficult for the families control also. Main ones that I'm going to focus on are potassium, phosphate, salt, and fluids, okay? So the first one, the potassium, the one I always get called about the most, it's the one we worry about because it can cause, you know, cardiac arrest, and it's also one of the most difficult ones to control. When I'm counselling families that need to be on a potassium restriction, I tell them that it's found in everything. We will get a baseline kind of diet history from these kids, and then try and fit it into families. So I have families that I've never seen before that will come to me saying, oh, I can't eat bananas, I can't drink juice, I can't do this, I can't do that. They've told me. And really what I try and do is I try and fit things that the children like within the restrictions. And this is, again, something that I'm going to come on to about empowering the families to recognise the restrictions that they need to be on and how can control it. Because, you know, what child, the minute you tell somebody they can't do something, they're going to do it. I can't eat bananas, I can't eat chocolate, when really, you know, I've never said to any of my families that they can't eat something, I promise you. What we will also look at is there other things that are causing the high potassium? And this is something that would be my job initially. If I get that call, so-and-so's potassium is high, what else is going on, okay? What else can we sort before having to actually make that child's life a bit more miserable than it might already be? And there's lots of different things that we can do to control it also. We rely heavily in the advanced stages of CKD with our patients on enteral feeding. And again, one of the ways that we control the electrolytes, specifically the potassium and the phosphate, is using a mixture of standard enteral feeds and these lower electrolyte feeds. We do things a bit differently in renal that some of the other dietitians think I'm crazy for, but really it's a balancing act, and quite often we will have to mix these products to maintain growth, number one, and to make sure that it's easy for the family, and then we're controlling the potassium, okay. Phosphate is another one that we look at. This is the one that we don't worry about so much like acutely like the potassium, but this is the one that we worry about longer term. If a child's phosphate is high long term, they tend not to grow as well, and also it can cause build up in the body, calcification of the heart, which can lead to heart disease, and we know that's one of the biggest mortality rates for our kidney patients in the end. Okay. Phosphate additives is something that is a new area that there's been lots of research put into. The main sources of phosphate, as you can see here, are typically dairy foods, but also things like Coca-Colas and even pre-packed food, manufacturers' food. Any sort of phosphate additive is rapidly uptaken in the body rather than if they were to eat just like a piece of cheese or some milk. So it's something that we would take a baseline diet history, find out what the family's routines are like, but also we would encourage the child to take a phosphate binder. That way they can sometimes have the food that they like, but also take the phosphate binder to control the levels in their blood. Okay. Fluids. So if you can imagine for our hemodialysis patients, not so much the PD patients, you've already got them on a potassium restriction potentially, you've already got them on a phosphate restriction, you've told them they can only have limited amounts of fruit juice, chocolate, milk, cheese, really is quite restriction. Then you come along with a fluid restriction, okay? We typically, again, we try to avoid having kind of lots of bottles of water about in the family home, trying to keep lots of juices and fluids away if they need that. Recording, we'll quite often give them a level that they've to have, and some children respond to it quite well to having like a large bottle of water that they can measure during the day, but it can be very difficult, and we have lots of patients who will just drink and drink and drink, and then it can affect their dialysis, potentially needing them to come for more sessions a week, and you can imagine the knock-on effect on the family routine for that. But it's something that's quite restrictive. We have a patient in at the moment, a little 2-month-old, who we're having to fluid restrict, and if you can imagine that mother, she's in hospital, she's already stressed. The only thing that she's doing for this patient is feeding her, and now this child is crying because they're hungry, but we have to medically restrict them, so it can be quite difficult. But again, it's educating the families on why we're doing this and why it's important to stick to. Salt, again, you've done the fluid, you've done the potassium, the phosphate, then you have to come along and tell them to stop eating potato chips. I find that, especially Glasgow, where I'm from, manufactured foods is really, really common, and I think families will have this on a daily basis. Takeaway foods, pre-packed foods, so again, it's trying to educate them to reduce the intake. Families or the children, if they have lots and lots of salty foods, they would tend to drink a lot of water as well, which again has a knock-on effect on their dialysis and having to remove extra fluids. But this is very difficult. Okay, so just a recap on that. The potassium we can control through the diet. Phosphate, we would encourage dietary restrictions, but also we have the benefit of using a couple of products of phosphate binders. Now, I was laughing, this quote at the bottom was taken from the National Kidney Foundation's website about the role of a dietitian, and it made me laugh, because when I tend to get calls saying here, the member of your healthcare team who will help you plan what to eat and drink and help you feel your best. But lots of families, when they know I'm coming to see them, they just have dread in their face because they think that I'm going to say, stop eating this, stop eating that. But I guess the point I'm trying to get across is that, it's all of our jobs to give the family this advice. And also the relationship I try to get with my chronic families especially is, encouraging them when they've been doing good, when their monthly labs come out or when they come to clinic, if their bloods are good, encouraging them with that. And then the next time if something's go wrong, they're more than likely to say, oh, do you know what, I've been doing this, I've been doing that. And then you can counsel them on what to change. So yeah, made me laugh. Sometimes doesn't feel like that. This is actually, I discovered recently, this is one of the new books that's come out from the British Dietetic Association. and it's kidney-friendly cookbook, but it's actually in Arabic. We have no resources at the moment for dietary restrictions in Arabic, so this is really good. So I'll send it out to the team, and hopefully we can get our catering team here at Sidra on board that can do some of the recipes. And again, it's that family involvement, because if you've got multiple children in the families, even the parents, when the child has a dietary restriction, the families really struggle because they want to give that child the same food that they're giving their other child. Mainly, the main concerns is that they want to give them potato chips or chocolate bars, and although you're trying to encourage the other children not to eat that, they still feel that they want to provide the same. It can be very, very difficult. This is the Qatar dietary guidelines. Now, this has come from the Ministry of Public Health, and again, every country has a similar guides. We have this resource in English and Arabic, and like Dr. Imam went on, there's a big focus now on healthy eating and CKD, whereas before, and quite typically, if you're trying to control somebody's potassium, the easiest thing to do is to ask them to stop eating fruit and vegetables, to stop drinking fruit juice, to stop even phosphate, to stop encouraging less processed foods, wholemeal, the kind of foods that you would be encouraging as part of a healthy diet. Typically, that's the things that we would restrict, but now there's more and more evidence showing that actually we need to start bringing these foods back in just for the cardiovascular protective issue. And it's shown that actually what we thought about phosphate before, kind of whole grains, for example, they're not rapidly absorbed as if you were to have takeaway foods. So really there's now a bit more push to get our CKD patients into a bit more healthy eating. So we're going to just recap on one of the, like we have here, the 8 golden rules. Take appropriate fluid intake. Thinking about this for CKD patients, again, it can be difficult, but also we have lots of patients that have really, really high fluid needs. The polyuric patients who they will just drink and drink and drink water. Really, then they have no appetite for other foods. We struggle with their growth. Check your blood pressure. When was the last time anyone had their blood pressure taken? The vaccine. Good one, Amanda. Well done. Check and control your blood sugar. Again, one of the leading cause of kidney disease is diabetes, so keeping that in check. Eating a healthy diet, but then this is, again, you try your best, but it can be difficult, but I think it's coming back to the Qatar dietary guidelines and trying to fit it in for everyone as part of a healthy diet. Keeping fit, being active, do not smoke, hopefully none of our children do that anyway, and check your kidney function regularly, and do not take over-the-counter painkillers often. So Dr. Imam, his last slide, I found this really interesting because, again, this is something that I've not actually thought about. This is a paper released by the World Kidney Day Association, one of the steering groups, and it's about living well with kidney disease by patient care partner empowerment. It's a bit of a handful. Kidney health for everyone, everywhere. And really, it's a really interesting paper, and it talks about, from a clinician's perspective, I'm mainly looking at growth. I'm mainly looking at controlling electrolytes. Are they eating enough? But really, what is the child thinking about, or what are the families thinking about? And this paper goes into detail about giving the child the empowerment, giving the families the empowerment. Quotes from the paper from adults. What does it mean to be living well with kidney disease? And typically, some of the patients, just getting out of bed at the morning, being able to go to work is huge. For our children, really, I think moving on from this and what we should work on over the next year is what are their goals? It might be my goal for so-and-so's phosphate to be in control, but really, if they want to be having a pizza with their brothers or sisters, I think my drive moving on from this is to be a bit more patient focused and a bit more working with the families in a bit more detail, I think. Okay, yeah, clinician's perspective. But really, and I think, again, like Catherine and Julianne will go into, kidney disease, it's multifaceted, and the main issues that we struggle with the families. They're coming very often, they're bored, they don't want to be on these restrictions, they don't want to be coming on dialysis, they don't want me going and telling them that they can't eat this and they can't eat that. So we really struggle, which is part of why the MDT is so important with keeping these families upbeat and keeping them in control. Okay, so I don't know if any of you know dietitians, but we're completely obsessed with growth charts. I'm going to go into a few case studies and just discuss, again, when I'm thinking about living well with kidney disease, more of a patient focus with these kids, okay? So looking at this growth chart, is everybody familiar with growth charts? Kind of. So on the left here, we have the child's weight, and on the right, they have height. Now, we want them always to be in proportion. When you're looking at this chart, a lot of you are probably thinking, what is going on? Number one, he's very underweight. Number two, he's really, really quite stunted. Now, this is one of our hemodialysis patients who's been on dialysis, I think, for 12 years. Looking at that, it looks quite bad, but actually he's in proportion. Now, this child comes to dialysis really quite badly fluid overloaded. His bloods, his phosphate are usually quite not well controlled. But actually, this child seems to be that, you know, his main enjoyment is having these KFCs. Every single day he has a KFC. He has a KFC before he comes to dialysis. Probably the father told me they have a fridge at home that they keep KFCs that they... From a dietitian's point of view, obviously I'm doing a very bad job. From a blood pressure control, from a fluid control, it's not ideal. His phosphate is usually through the roof. But really, when we think about that patient, that seems to be like one of the only things that he can control in his diet, you know. It's not ideal, but again, what would help him to make kind of small changes? This girl, so this is one of our... She's a really interesting case as well. This is one of our, she had a kidney transplant maybe 6 months ago. And I don't actually know how to work this to the pointer. You can see that actually she gained minimal weight. She was on PD for lots of years. She gained minimal weight, refused to have a G-tube, really had really quite bad bone disease, wasn't growing, really, again, significantly underweight. When we eventually got to the bottom of it, she had a disease where lots of her cousins have had it. She was the only child that was on dialysis, and she eventually said to me, you know, I just don't understand why I'm the only person on dialysis. Why have my cousins never had to do this? Why do I need another tube? I don't want to be different. I'm not getting it. I'm not getting it. And that was her kind of control. For me as a dietitian, I wasn't winning. She wasn't growing. She wasn't gaining weight. But for her, that was her control. And I guess I thought that's what she felt she was living well with. Eventually, you know, last year when coronavirus came out, she was forced to stay at home. She wasn't going to school. She came to the conclusion herself as she was at home and she saw all of her cousins developing, gaining weight, improving. She made the decision herself that she wanted a G-tube, and now that she's to help her gain weight, because she just felt like she was helping back. And again, that's bringing it back to that patient empowerment. Yes, we've got our goals, but what are the goals for this family? This is her now. And she's gained weight, yeah. I think we will struggle to see any height gain with her. She's 16 and she was quite significantly malnourished for a long time, but you know, she's happy. She's now had her G-tube out. This is our little superstar. So this is she. I think she was transplanted maybe a year and a half ago. Really quite involved family. Always wanted to know the lab results. Always wanted to know what they could change in her diet to keep her healthy. And if you see, you know, I think when we think of kidney disease, we always think of kind of underweight children. They're not going to grow anyway. So what's the point? When we look at her. In the past year, she's grown about 10 centimetres. The chart on the right is her height. She's nearly taller than me. She's nearly 6, I can hear you laughing, Emma. She's nearly 6 years old. And I think this just shows, you know, what can be achieved if the families understand what they need to do and how to move on. This patient is still on dialysis now. I think if you can see on her weight chart on the left, no weight gain for 2 years at all. She had a G-tube, the family wouldn't use it. It was too much of a family burden for them. They were already having the PD overnight, and really it was quite difficult to get them started. But again, absolutely no weight gain for 2 years. And then when you correspond that to her height on the right, it looked as though that was having an effect and she was stunting. She's actually okay right now. We started using the G-tube. Family got involved, and then it just kind of escalated, and she's nearly put on 20 kilos in the past year. We stopped the G-tube feeding a while ago, but then now we've cut in the other issue. She's on statins, she's got high cholesterol, and really, I guess, the family had been so focused on years on trying to make her grow and trying to maybe add in extra things like butter and oil to her foods that now the enteral feeding kind of just tipped her appetite off, and now she's a real struggle. But again, when we're thinking about when these children eventually get kidney transplants and they're living, then the focus is more on kind of the cardiovascular health. So I think this is pulling it back to the healthy eating and why we still need to be encouraging this for all of the families. Yeah, again, it can be very difficult. I think the over-restriction of the diet and the feeling that the children are getting into trouble or they're eating wrong things have led to often we find the children will eat in rooms by themselves, which socially is not ideal. They feel like it's their fault. They feel like, why can't I be eating with like at school or my friends and family? Why can't I have a McDonald's? It can be really hard on the families and the children. But again, this is why I think when I'm coming back to my focus for the next year, I'm going to be working a bit more with, what are the children's goals? What do they want? Are we making them grow? And just empowering them a bit more and being a bit more involved in their care, I think. Okay. So that's everything from me today. It's a bit of a whistle-stop tour for kidney disease and dietetics. Has anybody got any questions or anything they want me to go through in a bit more detail? No? Okay, thank you.
Thank you, Carolyn. So that's, now we've got a break. So if I can just ask you to be back here in about 30 minutes, please. Are we ready? Is everyone back? I think everyone's back, aren't they? Have we all enjoyed the morning session, guys? Yes? Feel free to tag the World Kidney Day in any pictures we take. Okay, so we'll get back to it. So next we have Catherine, who is our child life specialist on 7A and inpatient and dialysis. Catherine's got 11 years of experience working as a certified child life specialist and recreational therapist. She's also got a master's degree in human rights with an emphasis in children's rights. She's spent the last 8 years working with patients and families with chronic illness. Her favourite interventions are empowering play to infants with medical devices and engaging families in compliance plans. She has worked in nephrology at Sidra for 2 years, helping the children process medical trauma, develop coping skills, prepare patients for medical events, and engages in play and socialisation to remind kids that even in hospital, it's okay to have fun. So welcome, Catherine.
Okay, can you guys hear me okay? Perfect. I'm going to take off my mask for my own ease of breathing. Welcome, guys. The title today is Helping Kids Be Kids. So looking out, I obviously know a lot of you and work with you day to day. So hopefully some of this is just a refresher for you, but maybe it gives you a new thought in working with kids with all sorts of chronic conditions, not necessarily kidney disease only. So I have no relevant financial relationship with commercial interest to disclose. And we have 3 learning objectives today. I think my necklace is making a rustling sound. Our first one is to identify adjustment milestones across different developmental age groups. Our next one is to explore common reactions and responses to living with chronic illness. Joy, I don't like this feedback. How can I make this less feedbacky? Do you guys hear that feedback? Okay. We were trying that as an alternative, but we'll keep with this one. Is that okay? Okay. Exploring common reactions and responses to living with chronic illness for each age group, and identifying some strategies to support children and also their families. So when you think about your childhood, hopefully it's filled with memories of fun, friends, school, going to water parks, going in swimming pools, and really enjoyable things. And when you live with a chronic illness, it might also include painful procedures, boring and isolating admissions, and medicines. And this is a part of our role to make sure that kids still have typical experiences even when they live with chronic conditions and have healthcare encounters. When kids grow, their understanding of the world changes, and so it's important that when we're working with children, we don't just consider it a one and done on intervention. So the way that a child perceives the world in infancy is different than when they're a toddler, then a preschooler, then an adolescent, and then when they're an adult. So we really need to help kids to understand, process, and cope with these chronic conditions as they develop through their lifespan. So you guys are probably all very familiar with the different kind of age groups that we lump kids into, infants, toddler, preschool, school age, and teenage. In Qatar, we see a little bit of that age difference of what we consider adult versus teenage, but the brain doesn't fully develop until the age of 25. So when I say a teenager, think about someone whose brain is still in that later stage of developing, and so this might be our patients who are 17, 18, and even beyond that. As they transition into adult care, they still have some of these developmental considerations. And so when we're looking at different adjustment periods that these kids have when living with chronic conditions, when we think about the infant, what they're doing in this stage of their life as far as adjusting is they're learning to build trust and to build bonds. And so what does that mean for an infant to build trust? It means that when they cry, their needs are tended to, whether it's because they have a dirty diaper, they're hungry, they just need to be cuddled, or maybe they're in pain and they're in the hospital and they need someone to tend to their pain. And so we need to build those trusting relationships with kids, and we need to help them to develop bonds. Bonds with their caregivers, bonds with their nurses, bonds with their doctors. We're very fortunate here that we've got a smaller team in the sense that, like Saji with our PD patients has a really good relationship with these families because she sees them on the inpatient side, she sees them outpatient, and she builds these really tight bonds with families, and that's really important for infants. In the toddler age, we start to see that these kids are gaining independence, right? Their favorite word is no. It doesn't matter what you ask them. You can be like, hey, do you want this chocolate bar? And the answer is no, just because they're learning the power of that. And so we really need to think about how do we allow them to still be independent, to exert their control, and to develop a sense of themselves. And they're also learning their verbal communication, right? So they might be able to say a couple of words, but they can't say everything that they want. And this is why we have the terrible twos, because kids throw tantrums because they can't communicate what they want. They might use different strategies for that, but you think that maybe you'll tell a kid, can you show me what you want? And now they're in a hospital bed and they're not able to walk to where they need to be, or they have an IV line connected to them, so they have limited range of motion. And so they're really losing their ability to communicate and also to ambulate and be independent. And in our preschoolers, they're learning to cooperate. So when we're thinking about this age group, how do we involve them in cares so that they feel like they're a part of the care and the care is not just being done to them? And preschoolers also have magical thinking. And this is when they connect ideas that are maybe not related. So I stole a cookie from the cookie jar last night, and the next day was when I was getting my vaccine, just because it was routine. But now that's happened because I stole that cookie. So it's a punishment for something that's happened. So a lot of times kids at this age, if they're experiencing new hospital things for the first time, they might incorrectly identify that as being a consequence of something that they've maybe done otherwise in their life. And so we really need to make sure that we're supporting them and understanding that those events are separate. And with our school agers, they're learning how the world works, and they're very industrial. So they're not only small kids ask like, why, but the school agers ask how. And so they're really starting to be interested in like, well, how is my kidney not working? Or how does this dialysis help me to feel better? And they're really starting to process and understand that a little bit more. And so those are some of the considerations that we need to think of when we're working with that group. And our teenagers are starting to explore their identity outside of the family. And so they're discovering who they are as an individual, maybe trying on different personalities, trying to test their boundaries a little bit. And they're expected to be a little bit more independent. And so these kids might have a little bit more ownership in their treatment. On the dialysis ward, we sometimes see these kids are dropped off for dialysis and expected to manage their 3 or 4 hours of care by themselves, or maybe they're left alone in the inpatient side of things. At home, they might be expected to take their own medications, and they're starting to give more ownership of their condition and their care management to themselves. So I want to talk about temperament really quick, because I know that there's not a one-fit-all solution for every child. And so temperament, this is one definition of it, refers to the characteristic phenomenon of an individual's emotional nature, including his susceptibility to emotional stimulation, his customary strength and speed of response, the quality of his prevailing mood, and all the peculiarities of fluctuation and intensity of moods. These phenomena are regarded as dependent upon constitutional makeup and therefore largely hereditary in origin. So we know that every 2-year-old doesn't respond the same. We know that every 17-year-old doesn't respond the same, and a lot of that has to do with temperament. Now, we can teach kids to cope differently depending on what their temperament is, but I want you to just keep in mind that it's okay if a kid's not going to give you the response that you want, or they're going to have different needs while they're living with their chronic condition, because their temperament plays into that. But we have the ability to teach them tools and to support them so that based on the temperament of the child and the adjustment of that child, we can support them more adequately. Okay, so we're going to go through each age group a little bit and talk about some reactions and some supports. So when an infant's in the hospital, and a lot of this could also be applicable to acute illness as well, so you can think outside of your chronic illness brain as well. What an infant does when they're in the hospital is they want their needs to be met, right? They cry, they want to be responded to. They seek comfort from their caregivers, so involving parents in their care is extremely important. And they don't perceive that their cares are different. They don't go, well, gosh, my 2-month-old neighbor at home doesn't go to the hospital every week and have to get this stuff done to me, right? They don't know that this is different. And so helping them to feel loved and comfortable and supported in the hospital is so important, so that they really build that foundation of a good, healthy brain development, physical development, social, emotional development. And from a young age, when kids can sit up about 6 months, they prefer to sit for all of their cares. I know one of our favorite things in the hospital is to lie kids down for procedures, because it makes it feel easier for us. But think about a moment when you go to the dentist and they put you in that chair and all of a sudden you're lying back and you have to open your mouth, and then someone's staring over you and they've got tools and there's clanking and there's noises and there are vibrations, and it's just not a super comfortable experience. And every time we force a child to lie down, you're kind of simulating that similar experience to them. So as much as you can, honor a child's emotional safety and allowing them to be comfortable when we're doing cares and procedures. And so how can we support this population? One of the most important things we can do is supporting parents to be involved in cares. If it is a first-time parent who's in the hospital, they might not know how to do basic cares for a kid, like changing a nappy, and then add on top of that they've got maybe a drain, or they've got an IV line, or they've had a surgery. Parents are scared. They need to be supported in how to be a parent for their child. We need to be providing opportunities for developmental play. And when they're really small, that might just mean cuddling and cooing at a baby. When they're a little bit older, actually giving them toys and things to engage with. And we need to allow infants to explore medical equipment and devices, especially ones attached to their bodies. I know that we've had PD patients before who get admitted because they have line infections, and the parents are like, I swear I didn't do anything. And it doesn't surprise me when these kids are 1, 2, 3 years old, because what they're doing is they're like, hey, what's this tube on my body, right? When my parent's not looking, I'm touching it, I'm exploring it, I'm going to take this gauze off. And so giving kids opportunities to look at that equipment, maybe on a doll, or letting them explore it when the line is open, involving them in some of their cares to kind of look at it, is important. And infants learn by putting things in their mouth, right? And so a lot of times kids will do what they can to origami themselves and put tubes into their mouth. So giving them something of a similar texture to explore can be really helpful, and for them to understand what's happening. And like we mentioned, allowing kids to sit for carers can decrease distress. And this photo here is actually a very personal photo to me. So this is my niece, and she was born at 23 weeks, so she was very premature. And that's my sister, her mom, that is changing her diaper, and my mother, Nora's grandmother, who's behind her. And my sister is actually a palliative care doctor, so she's very familiar with the hospital setting. She's very comfortable with big, scary conversations, but this is her first child. It was a very unexpected delivery that had to happen quickly, and this is her getting to change Nora's diaper one of the first times, and getting to be involved in her cares. And how normal is it that her mom is also there supporting her, and I'm on the other side, like, documenting every moment, but it's so important that we help parents to feel involved in these cares. So when I think of the toddler age, this photo is a sweet little boy I worked with in West Africa, but I think his face just totally captures what it means to be a toddler. And I had asked him if he wanted to walk or be carried to the playground, and this was his answer. So you can imagine when it's a medical care, it can be a little bit more challenging. And so toddlers, they often refuse routine cares and cares that are unfamiliar to them, and they want to do tasks themselves, right? So doing a task to this population is not super helpful. These kids like to practice tying their shoes, even though they might not know how to, or buttoning buttons or zipping zips. They see those things and they want to try those things. So they might be curious to look at a blood pressure cuff and practice Velcroing it and releasing it, because they see that happening all the time. And giving them that opportunity can help them to then be a little bit more compliant with their cares. So to support these kids, it's really helpful to offer the medical equipment to be involved in cares, just like we were talking about a blood pressure cuff. If you have to do some cleaning, giving them like a little tiny clean alcohol pad to just hold or practice, telling them to, clean on the doll, or like clean mom's hand, or whatever it might be, but just to help them to feel engaged in it and to feel like they're a participant in the care. You want to be prepared and quick with this age. So they're squirmy and they have low attention spans. So a lot of times, Child Life will get called in to help the kid to be like calm and comfortable. And I'm like, are you ready to do the procedure? And they're like, yes, I'm ready. And then the kid's there, and we're calm and we're engaged, and we've been calm and engaged for 10 or 15 minutes. And then all of a sudden we start opening the sterile packs, and we're like, oh, this is the wrong size glove. Can we get the other gloves? And then the kid gets to like 17 minutes, and they're like, I'm done. I've been sitting for 17 minutes of my life, and they're ready to run. And so with this population, we really want to be mindful about how we're timing things. So is this a kid who can't tolerate cares for a long period of time, and we need to break those up so they can have periods of like playfulness and energetic release in between? Or are these kids who we just need to be quick and get it done with? But think about how you're approaching this child and with your medical equipment, so that they don't become distressed, because a lot of times their distress isn't necessarily what you're doing to them. It's about the length of time you're making them have to be still and be compliant, right? They have other things they want to do. They want to go and be independent. And then provide choices when possible. So you might get a response like this one, but asking them, do you want to sit with your mom or your dad? Or do you want me to look on your right hand or your left hand, things like that. And also with this age group, try not to apologize for your cares. It's something that we see a lot, but when we are teaching kids to say sorry, we teach them to say sorry because they've done something wrong. And so as nurses, when you have to do a painful procedure and you say sorry, the kid's like, well, we say sorry when we did something wrong, so why are you doing that mean thing to me and that thing that's not nice to me? And it internalizes what that healthcare experience is to them different than just saying, I know that that was hard, but you were so brave. So kind of reframe their perspective of it and remind them and encourage them of how well they're doing. Okay, our preschool kids. So a little bit before we were talking about the concept of magical thinking, and that's one of the biggest reactions, that kids might not understand why they've been brought to the hospital or why the cares are being done to them. So even though you might have a kid who in infancy was pretty happy, they were compliant with their cares, even as a toddler they were a little squirmy, but they were able to kind of engage with you, they still might not, if they're the kid who comes once a month to CKD clinic, they still might not have a really deep understanding of why they come to the hospital or their reasons for coming repeat times. And so they might get to this age where they're like, oh my gosh, is this because that bad thing I did? Or like, I've been trying to be really good, but mom keeps bringing me back to the hospital. And so don't just think that when the child is diagnosed, that's when these considerations happen. If a kid is diagnosed with a chronic illness in infancy, you will see these patterns emerge in each stage of their development. And so you'll see some regression in coping, and you'll see that they need to relearn their coping skills and develop their perspectives differently. The great thing about preschoolers is they're learning to cooperate, right? So they're meeting with peers, they're learning about sharing, taking turns, things like that. And so it's a really nice age where you can start to give them like jobs to do, like, okay, try to hold your breath, or try to hold still, or count to 10 for me, and then this part will be done. And so you can really start to engage them in the cares. And then they're also might be aware of their peers and that they're a little bit different. And their peers might be their siblings. So kids that they're at home with, and they say, hey, I noticed that my brother or sister doesn't have to do this. Why do I have to do this? And so they're starting to feel maybe a little bit different than other kids that they're around. So it's important that we explain why their cares are happening. We give them jobs to do. I love giving kids jobs to do. Most times in the hospital, their job is to hold still, take deep breaths, and tell us if you're in pain, right? So those are your three key jobs to keep in your mind. And so if you tell a kid, tell me when you're in pain, and then they tell you, you can kind of pause and honor that, right? And it helps them to feel empowered, like they're a participant in their care and not just a recipient of their care. So we want to help them to identify their feelings about the hospital. So helping them to say, I know that was scary when we had to do that blood draw, or I know it can be sad to have to miss the pool party because you have a hemodialysis line, but really helping them to identify their emotions can help them to process those things a little bit more, and it will empower them later in life to be able to reflect and process on their disease process. We want to teach kids how to respond to people asking about their chronic conditions. So I know some conditions are a little bit more prevalent than others, but if a kid has an HD line on them or a PD line, because they're interacting with their peers, they might have people other kids who might question them, or adults who question them about their lines or their things like, oh, are you sick? Or what's that thing on your chest? And so really helping kids to know how to say things like, I'm fine, thanks for asking, and shutting down a conversation, or them to say, that's my tube that helps me stay safe and helps my kidneys to be strong, right? You give them small words where they don't have to know the intricacies of what's happening, but to really empower them to be able to start talking about their condition, and that teaches them to be an advocate for themselves. We want to emphasize their cares as routine habits. Just like we brush our teeth and we wash our hands, we want anything that's routine about their cares to be ingrained into what they're doing. And so I know on the dialysis unit, the kids have pretty good routine. If they come in, they get weighed, they go and wash their hands, they go to their beds, right? And so those are really good things that you've built into their care routines, that those are just standard for them now. They're not stressful events that have to happen. And so anything that's a routine care for their chronic condition, really integrating it into their lifestyle, both in home and in the hospital. And we really want to promote play opportunities that are focused on creativity and role playing. And so when I talk about role playing, a lot of times in the hospital, that looks like medical play, right? So letting kids play in the role of a doctor or in a nurse, helping them to process procedures they've had or cares that they receive. And I'm sure a lot of you might, on the dialysis unit, recognize this little patient, even though he's completely masked. But this was a day where we just had fun, painting, pasting, cutting, doing normal things that a preschooler would want to do, that they would have that opportunity if they were in preschool. But sometimes these kids have limitations on what they can do because of their chronic condition. So maybe there's not a preschool option that accommodates dialysis time, and so they don't get those opportunities. So really allowing them to have those opportunities for normalization and play. And that doesn't mean you always have to be facilitating it, but a lot of times we are kind of the people who give them the resources to be able to do those things to help them. It can be really easy to plop an iPad in front of a kid and think, great, I did my work. But I'm sure, as all of us know, screen time is really not recommended for developing brains. And so while that seems like an easy solution that gets you a compliant kid, what that gets you is a really disengaged child who is just not coping with their condition at all. They're not being encouraged to grow and develop. What other child would you take to their home, strap them to a bed for 4 hours and say, don't do anything? You can't move from this, right? You're thirsty? I don't care. And when I can tend to your call bell, I'll take to it, right? Like this, it is not a normal situation, right? And so we need to create environments where kids don't feel like I'm strapped to this bed for 3 or 4 hours, or I'm stuck doing this vest treatment, or I have to do these nebulizers, or I have to do these daily finger pricks with diabetes or things like that. We want it to just be something that is something that happens, but you can still be a normal kid while you're doing it. So our school-age kids, what's really nice about this is usually this magical age of compliance if they've been supported when they were younger. They really love being successful. They're in school, they're learning about grades and like how to get praise and encouragement. And so school-agers are usually like, yeah, let's do this. This is awesome. What do I need to do? A, B, and C? Okay, we can do that. That's scary, but I can do it, right? They're really motivated to engage in their cares, especially if they've been adequately supported when they're younger. They ask a lot of questions about their illness and their cares, so they're awakening to their conditions. And so a lot of times kids will ask, well, why do I do this dialysis thing? And you're like, you had kidney disease your whole life. How do you not know, right? But they don't know because they weren't really aware of it, or it wasn't something that was important to them younger. And so really supporting kids and understanding what's happening at this age is so vital. And if they have a deep understanding starting at this age, then they're going to be more compliant when they're older because they really, truly do understand what's happening to them. They are learning how the world works and exploring outcomes and consequences. So this is a great time to start talking to them about, like, well, when you don't take your Pediasure, then your weight drops. And if your weight drops, then we might have to, give you a feeding tube or things like that. But you can kind of talk about those consequences and help kids process through those things. So like Carolyn talked about a patient earlier who wasn't really ready to accept that G-tube, and she was able to walk through that process a little bit and help that child to get to a point where they were able to accept that. And they definitely have an increased awareness about differences from their peers. So this is where they can start feeling a little bit more socially isolated. So it's really important that we're providing that education, reassessing that, encouraging kids to ask questions about their cares, involve the child in the cares, so explaining what's happening, and then encouraging them to connect with others who might have a similar condition. So the beauty of the internet and social media is that it's really easy to find kids that have other chronic conditions. It's really fun to see younger kids who have really embraced the social media and have helped to normalize some of those experiences. So like when kids are learning to drop NG tubes on themselves, I have a couple of kids that I like to show videos of that have made their own teaching videos about these things, and so it can really help kids to feel more supported. So here's a couple of our school-agers, all from Sidra Medicine, who've kind of doing some normal things. So we've got one little girl who's down in the playroom, and she was on bed rest after surgery, and she has some chronic conditions, and all she wanted to do was go to the playroom. So we made that happen, right? Those doors intentionally open big so that these kids can come into the playroom, and she was the only one in there. We couldn't fit another kid with her. But it's so important that you can make those things happen for kids. Otherwise, she just felt like, I'm sick, I'm in my room, I had this surgery, and now I can't do anything. We've got one of our former dialysis patients who celebrated her birthday with us. So what a great opportunity to just be a normal kid, right? Who does she see 3 times a week? She sees her dialysis staff. So it's appropriate to say, let's have a celebration, right? The family wanted to bring in cake. They wanted to, have treats and music and things like that. So providing those normal opportunities. And then this anesthesia plan is from one of our other patients who had really difficult anesthesia events prior to coming to Sidra and also within the Sidra system. And so I worked with him pretty extensively to start to process through those events and to have successful anesthesia. And at this point, he's had 3 successful anesthesia events that didn't require restraining and significant amounts of pre-medications. And he independently can complete his anesthesia events now. So he got to a point where he wanted to process through what was happening and to understand what was happening and why things happened and identifying his feelings and emotions related to that. And our teenagers, they're either thriving or failing at managing their cares. So depending on how they're supported before, they can kind of have some 2 extremes. So they're exploring their independence in things, and they might mismanage because they don't want to feel othered. And so these kids might decide that they don't need to take their medicine or they don't need to be compliant with their dietary guidelines or things like that because they want to test the boundaries and they want to see if anyone's watching or if they're truly independent. And they might be just kind of like pushing that boundary a little bit. And we need to continue to support them in a pediatric friendly way and not going down hard on them, but also helping them to gain that independence and understand that research shows that kids with chronic kidney disease actually rely on their parents significantly longer for management of their cares than with other chronic conditions. And so there's hard evidence to suggest that these teenagers might need to be managed a little bit longer with the support of their parents. And so being mindful of that even when they're of consenting age to still really engage the entire family. So including them in decision-making process, encourage independence, and then also encouraging peer support and helping support the parents too, because they might lose a sense of their identity as they're not the primary caregivers for their child anymore. So I know that was a brief overview, and my final takeaway is that children are not medical conditions, they have medical conditions. So a medical condition is one portion of the person that they are. As healthcare providers, we shape that part of their identity, and please remember to honor the person first. Finish. Charlotte asked if there was any questions.
Thank you very much. So please welcome our next speaker, Julianne, who is our social worker. Julianne joined Sidra in 2017 from the UK as a medical social worker. She's also a qualified nurse and social worker with over 20 years of experience working in various hospital settings as a qualified nephrology nurse and medical social worker. And she's currently pursuing a master's in public health. Her role at Sidra here is to assess the chronic kidney disease, dialysis and transplant patients and families' social situation and support system in order to formulate support plans and highlight their individual needs. So welcome to Julianne. Thank you.
Thank you, Charlotte, for that introduction, and welcome all. Happy Kidney Day, and happy Social Work Month, and happy Child Life Month. So March is a special month for us in the nephrology world, in social work, and in child life. I don't know about others, if there is anyone else in March. Oh yeah, Women's Day. How could I forget that? Okay, welcome. And my topic today is supporting patients with kidney disease, and we'll talk about the social work perspective. That picture on the front there was the first time I had to deal with a pediatric kidney patient. And that child was very upset that day. He had lost his nanny. His nanny had gone back, and he was attending dialysis on his own. So they would drop him and they would pick him up. So, and he struggled those first days when the nanny who used to escort him had left. And on this particular day, I was called by the team to see how we could help him, because he was pulling on the lines. He was very upset. And all we did was to sit with him. I sat with him for about an hour, I think, until he got up and went to his bed and completed the rest of the 3 hours. And at that point, I thought, okay, I know why I'm here. And our learning outcomes today will include to raise awareness of the psychosocial issues of patients with kidney disease, to have an understanding of the core function of social work in supporting families in the nephrology setting, and to emphasize the importance of patient family-centered approach throughout the continuum of care. So as social workers in nephrology, we see all the nephrology patients from, I didn't put CKD here because I didn't know how to show it, but we are involved with the CKD patients who are normally in the CKD clinic. We're involved with the hemodialysis patients, the PD patients, the peritoneal dialysis patients, and the transplant patients. The CKD patients, as I'm talking about it now, I'd like to encourage referrals, because we don't get to see a lot of them simply because we don't get the referrals. But it doesn't mean that we can't see them. When we get the referrals, we may not necessarily see them in clinic with you. We have a social work clinic where we can book them and see them in the social work clinic. It's easy, of course, to see them on the day that they come to clinic, but if we can't, then we can see them in the social work clinic. So what are the main psychosocial factors that affect our kidney patients? End-stage renal disease and renal replacement therapy can have a tremendous effect on the outcome of renal patients and their families. To fully appreciate the dynamic nature of the demands of renal patients, one must understand the patient's perspective on his or her ability to cope with the stresses of the renal disease. And this is not just the child, but the family, because most of our patients are young children, but their families are more involved and want to know more of what's going on. The person's personality, psychological functioning, resources, and even cultural beliefs may all affect the perception of their ability to respond successfully to the challenges posed by the renal disease. And that's when the social worker, often mistaken as a magician, comes in. As social workers, we'll complete a comprehensive biopsychosocial assessment in the pediatric renal patients. There are several issues we consider as part of our evaluation, social work evaluation, with a view to build a good foundation for the care plan and how to support them. The social work assessments are multidimensional and look at different aspects of the child and family's life. So we'll look at the age in the demographic data that we collect. How is it impacting this child? How is the disease impacting this child at that age? Do they understand what's going on? Have the parents explained it to them in a way that they understand. That's age appropriate. We ask about, often patients ask, why are you asking me about my housing? Why are you asking me where I live? But all these come into play because if the patient is going to go for the peritoneal dialysis modality, then they have to have the space, enough space for their treatment. The level of education, not just for the patient, but also for their parents or the caregiver, because they have to understand why they, for instance, giving a medication at a specific time. What is the health literacy? Once you know the level of education, that helps you understand how the patient or the family will receive the information that they're given and the education that they're given. Ethnic and cultural background. When I do my assessment, I know that there's certain things that you can't talk about, but you have to talk about. In our assessment, there is a question around alcohol and drugs. In the UK, I freely asked that question. I had no reservations. But here, I have to think about how is the culture here receiving that. So I have to think about how I'm phrasing the question and explaining myself. I tend to explain myself more why I'm asking that specific question, and I don't intend in any hurt or any offense. Legal guardianship. Our patients, a lot of our patients here, or I've come across so many patients here that have more than one home. Sometimes they're in their dad's home or a grandmother's home or an auntie's home. And with all the with everything that's going on in nephrology, the dietitian talked about the diet. Does everybody in every home understand what this child has to eat? Do they understand the renal diet? And then in the assessment, we talk about those different things once I know that this child has many different homes. The economic status of the family, especially now, the COVID situation has completely made this even a bigger problem. So many people have lost their jobs. What's the employment status of the parents? How are they going to navigate the dialysis plan for this child? The child has to come 3 times a week for dialysis. Is hemodialysis the better modality, or would peritoneal dialysis be better because of the employment status of the parents? They may not be able to bring the child to dialysis. Do they have health insurance? A lot of our patients here, I think only one family has insurance. The rest of the patients have had medical exemptions. Here in Sidra, medical exemptions, as we all know, since September, Hamad has stopped issuing medical exemptions. So we talk about that piece as well as we do the assessment. And some have medical exemptions that haven't expired, and Sidra still honors them. But what happens then when they expire? So we have to have that conversations with the parents and give them options on what the plan is. Eligibility for state benefits and entitlements. Here in Qatar or here in Sidra, we know that only the Qatari patients are eligible to state benefits and entitlements. So when I have the Qatari patient, I'm kind of relieved because I don't have to worry about the finance piece for the most part, because it's covered. So there is the cognitive piece. Growth and development. I think Catherine has touched on a bit of that, on the development of the children. How do they understand? At what stages? What are they understanding? Most of the time, I must admit, I'm speaking more to the families because they're the caregivers. They're the ones that are pretty much driving this agenda. what's the mental health status of the child and the parents, the perceptions of CKD and its implications. I will also look at how the diagnosis is going to the capability of the parent and the child to understand the renal replacement therapies. Sometimes I've met parents on the ward who say, oh, I've been told to do PD. Do you know why? What is PD? Why did you not choose hemodialysis? And they don't know that. And then they start to stress about that. Is that better? No, but then I've been told hemodialysis is more dangerous. It will give me a heart attack. And the kidney transplant process as well also causes a lot of stresses for these parents. And I find that a lot of patients and parents think that, and maybe some of us professionals think that transplant is the end, is the fix for renal disease. I always tell patients and their families that it's not, it's part of, it's treatment, because they still have to adhere to the medications, they still have to come to clinic. It's not the end, it's not the fix to renal failure, it's just a treatment. And it could fail and they could still come back to hemodialysis or peritoneal dialysis. So can you think of some of the other stresses the renal patients have that you have met in your clinics, for instance, or on the ward? Anybody? Dr. Imam, I'm sure you've had to deal with a lot of stresses in your patients in clinic. So there are many stresses. There could be the effects of the illness. You get a patient that is itching and they don't know why they're itching. That's in the CKD clinic, and the child is literally scratching their skin off because of they haven't taken any medication. They've only just come to clinic. They've been diagnosed, and maybe they've given them some medication, but they're not taking the calcitules or whatever they give them to help with the itching, and that's stressing the mom, is stressing the dad, is stressing the child. They're not sleeping. Family dynamics. We have some parents who are divorced and child lives in both homes. That causes a lot of stress for our patients. The dietary constraints that Carolyn was talking about earlier on today. What should we eat? Why can't I eat that? Why are all the others eating the good food and I can't eat the good food? The time restrictions of having to sit on that machine for 4 hours as a child. Imagine yourself as an adult strapped on that machine for 4 hours. That's stressful. There's the functional limitations. The child may not be able to do everything else that the peers are doing. They may not be able to go to school because they have to come to dialysis. The financial constraints, as we have already talked about, the relationships with staff. This is very important because I have seen patients walk in and they're like, oh, Suzanne is not on. Who is going to put my child on? And they just have those specific relationships with that, but they just trust those few nurses. And of course, we have to encourage them to not to have to peak, because that nurse may be off sick, that nurse may be on vacation. So we come in there and support those stresses. There is the awareness of impending death, which people don't actually talk about. We haven't lost any of our patients. I can't remember that we've lost any of our patients. But having come from adult nephrology, we had a lot of death. But in the pediatric family, I have found that it's not so much the patient that worries about that piece, it's the parent. might my child die? Would they die? How long can they go for if they don't get a transplant? Or if they get a transplant, is that it? I don't come back and they will not die. And we have to support them around that and understanding that it's a part of life and it's something that we can discuss and talk about and face, of course, in a supportive way, in a much more supportive way. Other psychosocial factors that we think about, especially in the transplant patients, adherence. Much as there's, we talk about adherence for the HD patients and the PD patients, it is so much emphasized in the transplant patients. Fluid restrictions. They have been used to having fluid restrictions as a dialysis patient, as a hemodialysis patient, and now they're transplanted and they have to take more, asking them to take more fluids. That's something that's very difficult for patients and that we have to talk about with families. How do we navigate that piece with the families? How do we encourage them? What are the strategies that we can use so that they can encourage the patients to drink more? Attending medical appointments hasn't been such an issue because I find that a lot of patients and a lot of our patients do come to clinics as prescribed. I don't know about the CKD clinic so much, but our HD patients and our PD patients and our transplant patients, they do actually come and they understand. The transplant patients really understand the importance of coming to clinic, however stressful it might be to come all the time. We also look at the unrealistic expectations. We talk about the realistic expectations, especially after the patient has had a transplant. Are they healthy? Yes, they're healthy. They're healthier than perhaps when they were on dialysis because they're doing more than they used to do when they were on dialysis. But we're not going to be asking them to run marathons. We're not going to be asking them to go to school every day because they've had a transplant. No, we've got to ease them in, and the parents, we need to speak with the parents and get them to understand that they're still patients, much as they're transplanted and they're feeling much better. And sometimes there's also the strain and tension in the family. There's usually tremendous amount of attention given to the patient child, and this may cause tension among siblings. Why is all the attention on this child? And we have to support the parents and the child themselves. Provide education, even for the siblings who are not on dialysis. Let them understand why their sibling is on dialysis. Why do they have to come 3 times a week with mom and you don't spend that time with mom, so that they can be supportive. And that's the family-centered approach that we will talk about later. Managing care across multiple homes, this is a real stressor as well, because you find that a parent will be complaining, or when she goes to grandma, they don't give her medication. She doesn't take her medication. And it's difficult for us in the hospital to manage that piece. So we have to support the families and the patients to understand, to find strategies on how they can navigate this piece, because it can be difficult. The grandma may not have the health literacy to understand why this child needs to take that medication. And there are others like treatment modality options, which we talked about. This transition to adult care that we haven't perhaps started doing here in Sidra, but we shall get to a point where we have to start preparing our patients to transition into adult care. We do have a couple of 17-year-olds, and I don't know how long we'll keep them here in the pediatric treatment, but social work will support with the transition. And transition is not very easy for these patients because they're used to being looked after we pamper them here, I must admit, but in adult care, it's more independent. And that can cause a lot of stress for these children as they transition into adult care. So, and this is the scope of social work in nephrology. We're not miracle workers. We're just part of the team that supports, just like the rest of you support these parents and patients. We assess and formulate recommendations for support plans for CKD, HD, and PD and transplant patients and their families. As social workers will collaborate with other professionals to evaluate patients' medical and physical conditions. We advocate for patients' needs both in hospital and in the community. And with the advocacy piece, as social workers, in the nephrology team, we are there to fill the gap in perspective. Sometimes the patients may not always be aligned, and social work, according to our code of ethics, we recognize that the patient is a core member of the team that brings expertise, and we have an obligation to advocate for them. We also support in conflict resolution when patients are having issues with other care providers. Please don't forget to call us. I've recently had a situation where security was called. And yes, it may have been the directive that if the patient is not compliant, call security. Sometimes you don't have to call security because when security comes, it makes the situation worse for this patient because the patient then, you can't talk with this patient. They are on the wall, their back is on the wall, and they want to fight. Whereas sometimes when you call the social workers, we can talk around these issues because sometimes these patients are struggling, the parents are struggling, and they don't know who to talk to. And the nurses are busy on the ward because there are other patients that they're attending to, and they don't have time to sit down with this person. When the security was called for this patient, it took me an hour and a half, myself and Jelos, trying to calm this father down. This father had just had an operation himself. So in my eyes, he was still a patient, and he's so stressed out. So as social workers, that's part of our role. Don't call security if you can call the social worker. If we can come and we are available, then we can come and support. We also provide support and counseling to the families that find themselves faced with circumstances of transplantation and commencing treatments like HD and PD. Like I said earlier, the CKD patients, please refer them to us before they start. It's a lot more difficult when you meet them on the ward and you didn't get a consult and the PD catheter is inserted. We do assess them, yes, but it's easier if we see them before they actually have the PD catheter inserted or the line inserted for HD. We prepare them better. And I'm not saying that you're not preparing them, but that's part of our role. We also develop support mechanisms for children and their families, whilst the child is resident in hospital, and we do this alongside child life. Sometimes it's very helpful when I have Catherine alongside in the unit, and she's with the child, and I get time to speak to the mom, especially for the children who are very connected to their parents, and they don't want their parents to leave their side. It's helpful when Catherine comes along to support the parent, and I'm speaking to the parent. We also facilitate referrals for patients and families to the community, to other community agencies, and resources such as financial assistance and durable activity equipment. Here in Qatar, the only community resource that we can go to for financial assistance is charity, and we can't guarantee that. Where we come from, we have British Kidney. For instance, in the UK, we've got the British Kidney Patient Association, who you're guaranteed will give you money for a patient if there is a need. Here we have to go through the whole application process, and we cannot guarantee that they will actually be supported. But I'm sure you all got the moratorium that is covering our patients. For the patients that don't have medical exemptions are covered for 2 months. And the other chronic patients, which include all our patients in nephro, are covered for the next 6 months. I'm worried that the 6 months will go through those very quickly, and the 2 months. And what we're doing now as social workers, we are applying to charity to support these patients. Once the moratorium is complete, and because I'm not sure what is going to happen after that, we may still go back to the same old issue of parents not being able to afford medication. And you know what it means for our nephrology patients. Not taking their medication is literally killing them, if I could put it straight up. Some of the other things that we do as social workers, we provide psychosocial counseling. We do end-stage renal disease and pre-transplant and post-transplant education. We have crisis intervention, some of which, like that example I've just told you about of the patient who was very upset on the ward and was almost going into fists with the staff. We also do interdisciplinary care planning and coordination in monthly and individual MDTs. Sometimes we may not be able to attend the MDTs, but please send us referrals or consults if anything comes up in the MDTs when we haven't attended. So that brings us to the patient-family-centered approach throughout the continuum of care. And when I was preparing this slide, I thought about the core concepts of patient-family-centered approach. And I know that Sidra is a patient-family-centered hospital, but how much of that do we do? So the concepts that I thought about were dignity and respect. As healthcare practitioners, we listen to our patients and honor our patient and family perspectives and choices. Patient and family knowledge, values, beliefs, and cultural backgrounds are also incorporated into the planning and the delivery of our care. Information sharing. It's important that as healthcare practitioners, we communicate and share complete and unbiased information with our patients and families in ways that are affirming and useful to them, in language that they understand. Patients and families receive timely, complete, and accurate information in order to effectively participate in the care and in their decision-making. And in participation, I thought about patients and their families. We've got to encourage them and support them in participating in care and decision-making at the level of their choice. Catherine, I think, talked about involving the patients and how much they can do. I was thinking of how we can involve our patients in the hemodialysis setting. Something as simple as weighing themselves. I do see patients weighing themselves. And a patient weighing themselves and taking that figure to the nurse and telling them, that's a good way of involving the patients. They feel that they're doing something for themselves. We're just not doing things for them. They're participating, and I think we'll get a lot more from them. In adult care, they do more. They take their own blood pressure. They will set up their pack, their dialysis pack. They'll open it up and make it ready for the nurse who's going to put them on the machine. Here, of course, they're children. And with infection control, I don't know how we can perhaps get the family or the mom who brings the child to participate in that way. There's the collaborations, patients, families, and healthcare practitioners and healthcare leaders to collaborate in policy and program development, implementation, and evaluation, in research, facility design, and in professional education, as well as in delivery of care. When I thought about the piece of the facility design, I remembered what the dialysis unit looked like when we first started and how plain it was for a pediatric dialysis unit. And I remember a mother saying, "Why can we not have some pictures here?" And I'm like, "Sorry, we can't. Why can't we?" And I didn't have an answer to that. But those are some of the things perhaps we can think about in the future. We cannot talk about renal or nephrology, and we don't talk about the impact of the COVID-19. COVID-19 has impacted every single one of us here, but more so our patients and their families. We've noted that there's been an increased utilization of healthcare consultations, so we don't get to see, of course, apart from the dialysis patients that we see 3 times a week, the PD patients for a long time, a lot of them we didn't see because we called them. The CKD clinic, I'm sure, Dr. Imam, most of your patients, you saw them, you had virtual consultations with them. We had 70%, Dion, of our clinic as a virtual clinic. And that impacted patients because sometimes the things that people can speak to you when they're looking at you as opposed to the telephone. When they're on the telephone, you don't know where they are, you don't know what environment they're in. They may not be able to speak, although they say, "Oh, it's okay, I can speak to you." There's been so much restrictiveness in the visiting policy, which is causing a lot of stress for these parents. A lot of them don't have support that they used to have before. They would have families fly in for periods of maybe 6 months to support them with childcare, with perhaps sitting with the other children while the parent brings the child to dialysis or brings the child to clinic. And it's been so restrictive and very, very stressful for patients. And it has actually taken us away from the family-centered care that I was talking about. Financial implications, there have been so many job losses. Expired medical exemptions have caused a lot of stress for our patients. And this is an ongoing situation, but we're working with the parents and the team to try and resolve this situation. Education, homeschooling has stressed out so many people, not just even renal patients. Everybody is complaining. I've never had a lot of people give respect to teachers until COVID-19 came, because homeschooling has been such a real issue for our families. Imagine they have to support the siblings at home with homeschooling, but they also have to come to clinic. Before the child goes to school, they don't have to worry about that piece. They worry about the sick child. Now they have to worry about both. The limited support available, like I mentioned earlier, there's social distancing. People are restricted to their own homes. Most of our families are expat families. They don't have enough support around them because they have to social distance. There have been immigration challenges that have caused so much pressure for our patients, expired QIDs, childcare planning, and there's the biggest fear, the biggest aspect of fear. COVID-related stresses further exacerbate an already stressful renal patient. Am I going to die because I'm a renal patient? That is a real issue and real fear for our patients and their families. And for recommendations before we end, please remember to liaise with the social worker. Send us consults and referrals. We are very short-staffed in the social work team, so our leaders have to to be careful and mindful of who the case goes to. Yes, I'm the one that knows nephrology more in my team, but I'm not available all the time. My colleagues could have to step in. So if you call for a social worker, sometimes we may not come then, but do put in a consult, and it will be considered, and they will allocate it to a worker. Continue with the values of family-centered care. Learn and be updated about the dialysis and transplant unit policies, rules, regulations, expectations, contact details of the providers, availability of services regarding end-stage renal disease. And these are changing, especially with COVID restrictions. They're changing all the time. Be aware of the patient support system resources, as well as their needs, strength, and sensitivities. Gain an understanding about the patient's method of communication with others close to them to determine whether the patient will ask for assistance and support when appropriate and needed. And lastly, self-care, not just for the patients, but for us as care providers. We cannot pour from an empty cup. We have to take care of ourselves first, then we can take care of our patients more appropriately. And these are the social work hours. We cover inpatient from Sunday to Thursday, the whole week, every day, 7 a.m. to 7 p.m. There will be a social worker in the building. Outpatients, 7 a.m. to 3 p.m. I think that's still correct. In on-call, we do cover on-call. Can you take a phone call to social work? No, I can't. We do cover on-call from 7 p.m. to 7 a.m. So when you're calling for a social worker on between 7 p.m. and 7 a.m., Vocera on-call social worker. That will go straight to the on-call phone. The weekend, we are here over the weekend, but the hours kind of, they do change from 8 a.m. to 4:30 p.m. Outpatients, we don't cover outpatients, and the on-call on the weekend is between 4:30 p.m. and 8 a.m. in the morning. And I would like to leave you with this, of what people think about social work. Our friends think, this is what they think we do as social workers. We're painting our nails. Although now that they see me in uniform, they're like, okay, because before we never wore uniform. we wore our clothes and we had our nail polish on, but now we have to, we're in clinical areas, we can't. What my mom thinks I do, she thinks I'm Mother Teresa and I help the whole world. What my clients think I do, and some of my colleagues, they think that I'm a magician. And what do I think I do? I think I carry the load of the whole world. And what does society think I do? I think that's probably a little accurate. A lot of people think we only look after children. They don't think about other things, other age groups. And what do I actually do? There's so much paperwork in social work, and that sometimes takes us away from the real things that we should be doing with the patients. Any questions or any thoughts? Shukran.
Any questions, Julianne? Yeah.
Thank you.
Thank you so much, Julianne. Thank you. Right, on to our last speaker now, Rebecca. Can I see her? Oh, yeah. Sorry. Sorry, Rebecca. Come on down. So welcome to Rebecca. She is one of our dialysis nurses. Rebecca has a vast amount of experience as a dialysis nurse, although we have to keep it quiet how long. She came to Sidra in 2017, previously worked in Saudi for 9 years and in Ireland for 12 years. She has also completed her postgraduate course in the UK in chronic kidney disease, so she's a very experienced nurse that works with us. Welcome to Rebecca.
Can you hear me?
Yeah, is that okay, Joy?
Okay. I'll just make this one short that I know that everybody is already starving. And also I know that everybody is already vaccinated, but still social distancing, okay? So today I'm going to discuss to you the dialysis is either the evolution. Our team is living well with the kidney disease. So if you have a kidney disease, we have the two, the peritoneal and the hemodialysis. I have to say this one, I don't have any relevant financial relationship because nobody offers. The evolution of dialysis. So history of dialysis, acute chronic disease and acute and chronic disease, if not treated, it leads to death. So in early Rome and Middle Ages, the treatments of uremia includes the hot bath, the bloodletting, the enemas, and the sweating. So that is the natural way. So in 1913, Dr. Abel, Roundtree, and Dr. Turner dialyzed anesthetized animals made from colloidal materials. These materials, before the blood routed to the dialyzer, it's clots. So they use hirudin as an anticoagulant. This anticoagulant is made from saliva of the leeches, which they used in 1880. The first dialysis involving humans was made by Dr. Haas. He dialyzed the first kidney patient, but it was not successful. Again, by 1928, he dialyzed the 6 patients, but again, what happened? Nothing. They all died. So on the seventh experiment, he used heparin. This heparin became the universal anticoagulant because it gets fewer reactions and fewer complications, while hirudin goes allergic reaction. The 6 patients usually died because of critical condition and insufficient effectiveness of dialysis. The first successful dialysis was made by Dr. Kolff. He used the rotating drum kidney. And this, he dialyzed the 60-year-old woman with ascites. And this, he became successful with this. And this became the breakthrough and even rotated and distributed his rotating kidney to Boston and different 22 hospitals. And this, due to rotating kidney, this rotating kidney further develops and he developed the parallel type of the dialyzer. So, just wait. Dr. Kolff's invention did not cure or intention of solving the chronic kidney disease. It's only solved the acute. So because these doctors believe that there's no man-made could replace the functions of the kidney for a long term. And besides, the patients undergoing dialysis suffer from veins and arteries. And then by 1960s, Dr. Scriber he developed the dialyzer. He made a plastic tube connecting the tube to veins and arteries as the first dialysis access. This one is the shunt. He inserted an artery. He inserted the tube to the artery and to the veins, and this was become the first dialysis access. If you can see here in this picture, the old one is just like, just dangerous, no? Because it's just like, if you will touch it, you will be electrocuted. But in this, the second one, we use this I was able to use this in Oman. But it is dangerous one because there's no built-in clamp, you know. There's a U-tube there, and then this clamp, you have to clamp on both sides and then remove the U-tube. And then the length of the heparin is according to the length of the U-tube. You have to remove the connector and put it on the betadine, and then see how the dialysis goes on now. with the connecting tube and from the artery to the veins. Then we have now the peritoneal dialysis. Peritoneum came from the word means peritoneum, means stretch out. The first recorded reference of peritoneal cavity appears in the papyrus, Ebers papyrus, which is from 1950 BC, from 1550 BC. An Englishman, Dr. Warwick, he dialyzed the 50-year-old woman with a severe ascites. He used the Bristol water and a claret wine, and then introduced it into the peritoneum with the use of the leather pipe. Imagine a leather pipe. And then this peritoneal, this woman, well, he was cured and the ascites subsided, but he suffers from severe pain. Then another German doctor, the first animal, he observed the metabolic. There's so many anatomists discovered the use of our peritoneal cavity. So they also discovered that the protein can be passed through, and then that is the use of the peritoneum cavity can remove large molecules, that the peritoneal also cavity can be as a therapeutic purposes because of this absorbed fluid, and they use that as in the severely dehydrated infant in which oral route is impossible. So by 1920, Dr. Cunningham recognized regardless of impulses, that is the one, and then by 1934, they also used, they add lactate to the solutions that can correct acidosis. Then by 1951, which just lately, Arthur Grolman used IPD in the uremic dogs and its application to human. He used a plastic tubing connected to the plastic bag, and he wants that this fluid to be infused by gravity, and then dwell for 30 minutes, and then drain until the biochemistry improves. So this is not what we call the intermittent method of peritoneal dialysis. If you can see here, the fill, the dwell, and the drain. When I was in Oman, we have using this. This plastic tube or this solution has no also built-in clamps. So we have to use the IV tubings and then just calibrate, label it 100, 200, how many ml of solution, and then clamp and then remove. And then if the patient wants to go, you have to remove it. And then, but the patient is always admitted. So we will now we will have a short tour for we call it Museum of Dialysis. So from the museum, you will see the door, the father of dialysis. He is the William Dr. Cohan Wolf. And then this is Dr. Scriber. He's the one who made the first dialysis access. And then we have here Clyde Desherdes. He is the first patient who survived with the first chronic kidney disease for 20 years. He died only because of complications. And the father of dialysis 7 is Dr. Imam. Yeah. And then now we go to the evolution of dialysis machines. We have here peritoneal, we have the cycler, which was 1984. We have used that in, I was not there in Saudi yet, but I have able to use this when I was in PD. And then we have now the new one, the home care Claria, which we're having it now. And then this is the first dialyzer, the rotating kidney. When I was having my training in the Philippines, National Kidney of the Philippines, I saw this one, but it's just a display. No, we have one patient, but once it is used, you can see rotating, and all the water is all over on the floor. But this one was just a display by Dr. Alano. And then this is the further development of dialyzer. From the killed dialyzer to a flat dialyzer, which is 1974. We use this in Saudi, but this is very difficult to rinse back because you have to turn side, you turn side, you have to turn upside down because of the bloods are sticking on this parallel type. Then we have here the hollow fiber. Yeah, this is the latest hollow fiber we are using. And then this is we call this the wet dialyzers. We use this in Saudi if the patient is having allergy reaction to any dialyzer we are using. But these wet dialyzers contains vitamins. That's why it's too expensive and it's not, it's not really being practical to use. Then we have here the evolutions of dialysis machine. This is the Travenor type. I have seen this when I was in National Kidney Center of the Philippines. But during those days, we are not allowed to handle the machines. It is only now, because we have our own technicians, it is only now that the extended role of dialysis nurse that we can prime, we can do everything to the machines. Then we have here the home person memo. This is the Ready 2000. This Ready 2000, we use this in Saudi for emergency, especially those patients who are having drug toxicity and blood poisoning. Because if you can see the filter on the side, that is with the charcoal, and that is also, this filter also used by our astronauts when they went to the moon, the first people in the moon. Do you remember them? Oh, you know, we have Neil Armstrong, Collins. I forgot the other one. Then we have this Gambro AK-10. We use this also for the patients who will undergo dialysis for acetate. Because before we have the acetate and the bicarb. Now we got only the bicarb. But this machine is calculation is manual, removing UF, the negative and the positive. The arterial will be the negative and the venous will be the positive. If you have 1,000, the arterial should be 500 and the venous will be also 500. That's the way how we get the UF. And this is the Cove C3. We have also that in Saudi. We're very sensitive. And now this is the Fresenius 2008. This is the first machine we have in Oman. And then it was here now the 4008H. We have 2 pumps here. We are still using this because this is a very friendly user. We have here the 2 pumps because we also used before the HDF. Then now we have here the 5008, which we have just the latest, but we have still the latest one, 2006. So living well with kidney disease is the care. Once you are diagnosed as or you are attending the low clearance clinic, you will meet some of our multidisciplinary partners or team. So I include here the family members because this is the most important. Since we are the family centered in Sidra, the family members also included. So once you are sick or once you don't feel well, whom are you looking for? Are you looking for somebody? You are looking for our members of the family, right? Just to offer a single glass of water is very helpful. Or saying that, when will be your next appointment to the doctors? I will go with you and just tell me because I can request for an off. Isn't it? It is very comforting. Rather than say you will go alone and then you will stay there and you will be there waiting for the doctors, and then after that talking sometimes, then sometimes they don't like what was revealed to you. It's so hurting, right? And so sad sitting there alone. Because when I was in Ireland, I can see all the people there sitting alone and then there's nobody. You know, but because in those Western countries, they always independent. And then we have here I will not discuss with you the social worker because it's been discussed, the dietitian has been discussed, psychologist, and then, but the transplant coordinator, we will let you talk to our transplant coordinator because so that you will know the criteria to be in the transplant pool, To be in the transplant pool is not just say, I want to be transplanted. You have to follow some criteria. And of course, have you ever talked also to the person, say, undergoing some treatment, say, before my kidney fails, I was working. So you can resume to work. You can resume to work, but there are some private and government sectors that offers a flexi time. Flexi time, yeah, in Ireland we have the flexi time. It is a mandate that a person with a chronic kidney disease should be offered with a flexi time. Then we have also can travel. I used to travel, so you can travel. You can have, it's either you are PD or hemodialysis. In hemo, you have to arrange, we will give you some list because there are some units or some dialysis unit that offer a transient patient. But you have to inform us because we will submit to them the requirements or all your blood results. And then if you are PD, we will lend you our suit for your machines, and then we will contact some institution there that they give you. The solution will be get from the place where you want to go. You are not bringing with you your solutions. And then activities, you can engage your normal activities, exercise. You can do exercise, but with limitations. If you are in perm-cut, you cannot do swimming. If you are in PD, you cannot do also swimming. If you are on fistula, you cannot do heavy liftings. And then if you are very much compliant, and of course your participation and compliance is very much in demand, is very much needed, is very much, then you can fly like a butterfly here. Yeah, you can resume your normal work. You cannot only resume, this one is running, but here you can fly. Because the most important things is your compliance and participation so that you can have a well-living kidney disease. Thank you.
Thank you very much, Rebecca. Then any questions? No, so that comes to the end of our symposium. Any questions for anybody? Oh, hang on a second. No? So I'd just again like to take this opportunity to thank each and every one of the speakers today for taking their time out of the busy days to come and teach us all, so thank you. Also again, I did mention this morning, but the people of the planning committee who has helped bring it all together, and thank you everyone for coming. We will have some decorations on 7A, but obviously due to, sorry, I just want to recognise that we will be taking some time to celebrate with the children as well. After all, they are the most important people here as well, aren't they? We will be having some decorations and some celebrations on 7A. I would like to invite you all, but obviously due to the COVID situation that won't be able to happen. But thanks again to everybody. And Joy up there. Joy, have you any other? No? Perfect. Okay, guys. Should we have a picture as well? Oh, thank you. Thank you, guys. So to everyone. Thank you. We'd just like to take a picture if you all would mind just socially distancing on the stage. With the Godfather. At the top? Yeah. I think, Joy, have you got the camera? If we take it. I know, yeah, you're right. your mask. Hold on. Hold on, one more. Back up pictures. Yes, Emma, we can see you smiling. 1, 2, 3, smile. Thank you. We just have one from the top so we can get the stage. Yeah, sure. Oh, yeah, then I'll turn on the stage. Yeah. I won't be able to get you guys from top. You will have to come to the stage. Can you help us? I can from, it will be hard for the back ones if we, there's enough, there's only a little bit of us because social distance is required to take a picture. Okay, let's just be mindful of the people. That's okay, I'll fix you guys. Charlotte? Yeah, I don't want to get flagged for the, like that. That's fine. Well, because it's a, okay. It will be okay, okay. Emma? Charlotte? We're good. There you go. Maybe even sing the national anthem. All right, go ahead. Sorry, I'm gonna take a step out. Come on, Marga. Smile, everyone.
No, we should do what Russia does. His love hearts. Let's do the heart. Let's do the heart, so. Do the heart. I mean, it's technically it's still like hearts.
All right. 1, 2, 3. One more, hold on. One.
I'm the one. Okay. Professional with the camera. On the website.
Sorry. I'm the one in there.
Come on, Joy. You can see here. Let's go, Joy.
Don't fly. I'm applying the 8 golden, one of the 8 golden rules today. I know.
Where's Rebecca?
Okay.
Rebecca is here.
With godfather. All right. Oh.